Szanowni Państwo, prosimy o zajmowanie miejsc. Już za chwilę zaczynamy Kongres Gospodarka i Zdrowie.
Ladies and gentlemen, kindly take your seats.
I teraz już na górę kierujecie osoby. Tak. Teraz już górą. Dzień dobry Państwu. Ja nazywam się Kuba Sita i mam niezwykłą przyjemność powitać Państwa.
Good morning, ladies and gentlemen. My name is Kuba Sitas. It's my great pleasure to welcome you to the first Congress, Economy and Health. We are inviting you to sessions and presentations focusing on economic and health-related security. The crisis connected with the pandemic is combined with long and midterm challenges connected with the results of demographic and climate changes, coupled with the war in Ukraine, the energy crisis, humanitarian crisis, as well as economic crisis. Therefore, the rethinking of in-depth relationships between health and economy needs a redefinition. Welcome to all the guests, both online and in person. Among us are 27 outstanding experts who will be sharing their knowledge and experience with us. Ladies and gentlemen, the organizers of the Congress on Economy and Health are Warsaw School of Economics. Welcome to the president of Warsaw School of Economics, Professor Piotr Wachowiak. Also, the capital city of Warsaw, welcome to the deputy mayor, Renata Kaznowska. The co-organizers, one of the co-organizers is also the Foundation of Economy and Public Administration as part of the Open Economy Summit, based on open society values, organizing and disseminating the economics of values. That's also a think tank related to deepening all sorts of values, and I'd like to welcome the Open Eyes Economy Summit and Health and Economics Professor Jerzy Hausner. Also, among the partners with us, Paul Fatar-Humming, Business Center Club, Radio Z, and the main media patron is wyborcza.pl. I'd like to request that Ma'am Renata Kaznowska, Deputy Mayor of Warsaw, please open the Congress. Over to you, ma'am. Dear ladies and gentlemen, welcome wholeheartedly on my own behalf and that of the Mayor of Warsaw, Rafał Trzaskowski. Ladies and gentlemen, dear participants, guests and observers of today's event, on my own behalf and that of all the residents of Warsaw, I'd like to welcome you all to Warsaw. It's my great pleasure that Warsaw should be a co-organizer and host of the first edition of the International Congress, Economy and Health, wholly devoted to health and economic security. I also like to thank Warsaw School of Economics and the Foundation of Economy and Public Administration, without which this event wouldn't take place. The Congress is being held at the moment where problems of the contemporary world make challenges connected to health stand out at the time of huge problems connected with climate challenges that impact the health condition of the society a lot. The challenges that we are all facing are tremendous. During today's meeting, we'll be trying to pay special attention to the problems that have surfaced as a result of the pandemic and the economic crisis. As we know, health is a very important component of the functioning of the economy. The interrelationship between the health system and the economy is indubitable. These relationships are multifaceted and often very complex. Other than that, new circumstances occur, such as new demographic challenges and the consequences of climate change. Therefore, we need an interdisciplinary approach to the issue and multifaceted discussion. I'm convinced that our initiative will pave the way towards something meaningful and will be continued in the years to come. I believe that the Congress will be an opportunity for debate, the formulation, diagnosing, and proposing solutions on the threats and possible solutions to health problems. I wish you a fruitful discussion, and I'm convinced that the conclusions formulated will inspire everyone to take new challenges. Rafał Trzaskowski, Mayor of the capital city of Warsaw, and I personally join in wishing you a fruitful discussion. Welcome to Warsaw. Thank you. Thank you very much, Ma'am Mayor, for your intervention. And I'd like to ask the host of the Congress, President of the Warsaw School of Economics, Professor Piotr Wachowiak. Good morning. I bid you all welcome wholeheartedly, those gathered in the main auditorium of the Warsaw School of Economics, as well as all the online attendees. For our university, for our community, it's a very important day. The first Congress connected with a very important topic. I believe that the words that are most frequently uttered, I tried to Google it out, how many times a day these words are being uttered, and it's really a huge number. That's the economy and the word health. I believe that health has also assumed a different value after the pandemic. And the economy has also assumed a different value after that terrible situation, the terrible war in Ukraine, which should end as soon as possible in a victory of Ukraine. I'd like to take this opportunity to thank Mr. Mayor Rafał Trzaskowski for his trust and cooperation. But even more wholeheartedly, I'd like to thank Ma'am Deputy Mayor Renata Kaznowska, because without you, this Congress would not be taking place today. I thank you for your cooperation, and I'm hoping for continuing cooperation going forward. A very important person, however, is a very modest person. One could say the father of this Congress, a person who always sits on the side, but that's characteristic of Mr. Professor Jerzy Hausner. Many thanks, Professor. We talked about it over a year ago, and we managed, owing to the joint effort of the three organizations that are mentioned here, to organize the Congress. I think we can, and I believe that the professor deserves a huge round of applause. I believe that the connection between the economy and health is visible. That health impacts the economy because if we have a healthy society, that society is more effective and efficient, and its skills and competences can be better used in the economy. Whereas if we have a healthy economy, we have more money for healthcare. These are also public means that have to be very efficiently managed. Every zloty counts, and it should be flipped over and over before it's spent, because there's a scarcity of public means for health. However, maybe the point is not to make sure that it should be so plentiful. It's rather about making sure that the money is spent more effectively, more efficiently on real needs connected with healthcare. First of all, on prevention, because if we have good prevention practices, we have a healthier society. And like I said, then we also have a healthier economy. So I'm very happy and pleased that the discussion on this topic will be held on the premises of our university, that there are very technical, substantive panels with the participation of outstanding experts in health care, economy of healthcare, and also importantly, economic practitioners. And as I look at Ma'am Mayor, it's also important to have representatives of local governments. I wish you a lot of satisfaction derived from your participation in the first Congress, Economy and Health. I bid you all welcome once again to Warsaw and Warsaw School of Economics. Wish you all the best. First of all, lots of health, and that the economy should thrive. Thank you very much. Thank you very much, Mr. President, for the introduction. Like I mentioned, there are 27 experts who will share their perspective. Let's start with the first one: the health and economy opportunities, challenges, and the future of health sectors. We'll ask Francesca Colombo, Director of the Department of Health in the Organization of Economic Cooperation and Development. She's a very outstanding expert who has advised on numerous governments on healthcare and economy in various countries. Over to you, ma'am.
Thank you very much. I will be speaking in English, so I hope you can understand. If not, I presume there is an interpretation. I was listening. I don't speak any Polish. I'm really, really delighted to be here today. I will make a little bit of a broad perspective on health and economy, drawing from some of the work that we have been doing in OECD, and I hope that you can see the slides, and I hope I can make this work. Let me see, yes. So it has already been mentioned, and probably I don't need to spend much time. There are obviously two-way links, strong links between health and the economy, and that happens at all different stages of an individual's life. When you look at early age, children who are in good health, and this is through work that we have done and data we have looked at the OECD, tend to be better performing at school. So there are really direct relationship between that good health and the ability to thrive in education. But also when you look at adolescents, ill health is more associated with individuals not being either in education or in training or even in employment. And again, that's a quite strong association. And with adults, of course, there are really strong relationship again between the health and the participation in the labor market, as well as ages that individuals earn. And it's also the other way around, that for those who are poor, least educated, which have less disadvantages, they also are more likely to be in poor health. Another way to look at that is to consider some of the risk factors, which again, and that's through work that we do in the economics of public health, are strongly associated with some more negative economic indicators. And so, for example, individuals who are overweight or obese are not only more likely to see a reduction in life expectancies. These are dates which are shown here from Poland in the order of nearly four years. But they're also more likely to contribute to higher health expenditures and to perform less well in school, 15% chances to perform well if you are in healthy weight, as well as having reductions, contributing to the reductions in GDP. And this is things that we generated through specific simulations models that look at what are, on the one hand, the consequences of risk factors such as obesity and overweight on economic, labor markets and GDP variables, but also look at the cost effectiveness of interventions to tackle obesity and overweight. So those links are well known, and I probably don't need to explain to you. There's the question of how much, obviously the health system itself contributes to have those positive results. And there are examples and evidence as well that shows that while a lot of determinants which are outside the health systems are obviously fundamental in influencing the health of the population, a good high-performing health systems does make a difference. And so even things like spending on health, which is a very, very, very rough variables, obviously, of the performance of the health system, and we know there is a huge amount of waste in a health system. Well, through econometric analysis that we've done, we have seen that for OECD countries, which are generally high and middle-high income countries, spending more tends to be associated with better outcomes as well. But the challenges are multiple, and they've been mentioned also and alluded to at the beginning of the presentation. Health systems actually are struggling, and they have been struggling even more in the context of the current crisis that we have seen. They're struggling to deliver good health for populations. I did mention this waste. We have done some work some years ago that shown that up to 20, or in some cases even 30% of health spending is actually wasted. So it does not contribute to delivering higher outcomes, and in some cases it can even be associated with risk for populations. Think about issues like safety lapses that happen in health systems, many of which are preventable. But they also have been struggling to transform themselves, to be much more ready for pandemics, like we have seen in the case of COVID-19, and to adapt to megatrends which are affecting societies, economies, and health systems. And I just want to give some examples of how health systems are not being ready. This is probably something which is well known to you. It's data that shows the excess mortality that we have seen throughout 3 different years of the pandemic in a number of countries, and I've put Poland in red relative to other countries. So it shows the increase in mortality rates relative to an average across 4 years prior to the pandemic, the immediate 4 years prior to the pandemic. And we see that both in 2020, particularly in 2021, but also in 2022, and this is true for Poland, but for really nearly all OECD countries, there have been a mortality in excess than what could have been expected. Many different reasons that explains that, of course, but one of that is that health systems were not resilient enough to face an unexpected shock of the kind that we have seen during the pandemic, and I'll say a few words later. But I wanted to mention also other issues, and one is related to aging of the populations. Obviously, it's like high-income countries are going through a rapid aging of the population with a shift in demographics needs and demands as well. And these demands somehow is not being reflected adequately in terms of even the type of resources and human resources which are available in the health sector. So this graph shows, looking at the past 20 years, between the year 2000 and 2020, the increase that we have seen in the share of the population age 80, which we can use as a proxy for higher needs, because with aging populations also have higher health needs. So there has been a 60% increase in the share of the population aged over 80. But if we look at the increase in the training of doctors and nurses, we have seen that that has not kept up, even in terms of sheer numbers, with the aging of the populations. And so in a way, we have been facing some megatrends which, in a way that had not perhaps, as with a true indicator like this, not managed to have a health system ready even before the pandemic, let alone obviously all the challenges that happen through an unexpected shocks like the pandemic. But there are other challenges, and again, I think it's been mentioned in the opening, which have to do, for example, with climate change. There's an increasing demand on health system to be much more ready to face climate change, both in terms of being climate resilient, think about new health needs of populations linked to heat waves, for example, but also to themselves reduce the impact that the health system has on the climate, on the environment. And here is a chart. It's based actually on work not done at OECD, but we're going to go and look into refining and improving those numbers as well, which estimates the contributions of the healthcare systems to greenhouse gas emissions for a number of countries. And so it shows that the percentage of greenhouse emissions which can be linked to the health sectors is actually quite high. It's about 4 to 5% of total global greenhouse emissions, with differences across countries that depends on the structure of the health systems, also on the level of health spending, on the energy intensity of the economy, and on the energy intensity of the health systems. So the health system itself can make contributions to addressing climate change by becoming more carbon neutral. Many different ways, think about having less reliance on hospitals and much more on the primary care, or think about clearly making investments in areas that have synergic effects, like the way we eat, the way we move, urban planning, and so forth, in a way that improves the health of the population, but also reduces the contributions to climate emissions. So those challenges are huge. They're not just linked to COVID-19, they're linked also to those pre-existing megatrends. And health systems have been really unable to adapt themselves, partly because if we look at the structures and the organization of health system, is actually quite rigid. Think about health system, how they looked like decades ago, and we look at now. Yes, there's been some transformation, but not as deep transformations as we have seen in other sectors of the economy that have been really transformed themselves thanks to digitalization, thanks to other opportunities. So health systems generally quite rigid. And there are perhaps, and I will highlight maybe 6 main areas for transformations of the health system, which link to some of the main areas that we have identified in recent works on building more resilient health systems following the pandemic. And those are some of the key priorities for actions where health systems are somehow struggling, but where we must make transformative changes for the future in order to be better ready to face a future unexpected shocks, as well as more slow-moving megatrends that are affecting societies and health systems. And they're related to population health, to health workforce retention, to data collection and use, international collaboration, supply chain resilience, and trust and leadership and governance. So let me just show one slide for each of them. Apologies. So the first one, and it has been alluded to and mentioned already, it's the importance of promoting healthier populations. It's quite shocking that across OECD countries, less than 3% of total health expenditure is actually devoted to public health and preventions, and that affects particularly the most vulnerable population groups. And this slide shows the rate, the mortality rates in COVID-19 of individuals who lived in most deprived areas relative to individuals that lived in less deprived areas. So it's an indicator of disadvantage. And we see that those who live in disadvantaged areas are more likely to have higher mortality rates, and the order of magnitude is quite large, twice, nearly 3 times in some cases, higher mortality rates through COVID-19. And this is true no matter what marker of vulnerability you look at. Here is in terms of individuals living in less or more deprived areas, but also if we look at other indicators like income or even race, those who are more disadvantaged population groups systematically were at highest risk of dying. And those were individuals that generally have poorer health lifestyles, less good health linked to poor ways of living, eating, moving, and so forth. So that's the very first area in which more action needs to be done, particularly because it's not really the priority for health system. We have health systems that focus more on volumes and delivery of services rather than improving the health through prevention and public health. The second area has to do with the health workforce. And this graph shows in quadrants different countries where they are situated relative to an OECD average on 2 variables. On the one hand, in the x-axis, it's the number of health workers, health and social care workers, so the long-term care, the aged care workers, and on the y-axis, it's excess mortality. And we have also done some, econometric analysis to show that. But what it shows is that the countries that had more health workers are more associated with having lower excess mortality. And you can see that Poland is unfortunately in the quadrant of higher excess mortality as well as lower healthcare workers. So we have done analysis looking at all different types of possible variables, and health workforce is actually the one that showed the greatest association between the outcomes of the pandemic and the variable itself. So it shows the need for investing more in training and in training health professionals. A third area where more investments and more attention is needed has to do with data. We know the health systems are, it's often said, data rich, huge amount of data generated on a daily basis through the encounter that each patient has in health systems, but actually the information poor. So the ability to leverage this data to influence both policy, research, as well as surveillance and care is actually quite poor. Now, these graphs, it's a little bit difficult to read, but it shows different countries, and it shows what is the percentage of key data sets in the health system, which are A, available, and that's the darker blue, and B, linked on a regular basis, linked at the individual level. And we see that while in a number of countries there are a number of key data sets which are available, the ability of countries actually to link them on a regular basis to support research, to support clinical care, to support surveillance, it's much less. It means that we have a lot of data, but we're not bringing them together in a way that stimulates those improvements in values, in research, and in clinical care. And that's an area where much more work is needed. A couple of existing areas. It's the complex one of pharmaceuticals innovation. There are huge questions about the ability of pharmaceutical markets to deliver improved outcomes for populations. This is just one graph that shows the increase in prices for some pharmaceutical products in the United States, which have been actually quite exponential over the years. There are huge questions about the ability of pharmaceutical markets to really deliver improved outcomes given the skyrocketing prices of pharmaceuticals, in particular areas like oncology, orphan drugs, and so forth. On the other hand, there is a lot of questions about how do we pay for global public goods like vaccines or antibiotics, for which the innovation models sometimes struggle to deliver. A couple of last things, it's promoting this supply chain resilience, again, through pandemic. This has been shown to be a problem in ability to really have enough medical products that will be available for populations, for the health systems. And this graph shows for some products like ventilators, personal protective equipment, and testing materials, the number of countries that experience reductions either at the beginning of the pandemic, that's the bottom part of the bar, or throughout the pandemics. And for those products in particular, there has been supply chain disruption that demonstrates the need for having better market intelligence, but also smarter procurement and possibly strategic stockpiles when it comes to those products. And the last area which I wanted to show, which has to do more with the governance and trust in health system, has to do with reorienting health system to be much more about what populations needs and value. This shows just the results of a multivariate regression analysis, and those are the coefficients. But it essentially shows that the probability of agreeing with the statement that health system performed well is higher when health systems have certain characteristics, like there is greater choice for individuals, more co-production involvement of doctors in the delivery of care, more integration of care. So a number more of soft. It's not just having enough doctors, having enough spending, but some soft variables about how health systems are delivering to people, which actually are associated with better performance. And I will conclude just saying, so yes, there are important two-way relationship between health and health performance and economic performance. There are significant challenges, shocks that we have seen through pandemic, but also pre-existing megatrends that challenge health systems. To respond to that, we need to think about new, different ways to adapt health systems with some key areas for improvements, and I focused on 6 in which we think health systems are still struggling behind and must make positive change in order to be better ready for the future. Quite clearly, all of this needs also to be underpinned by strong policy action and collaboration, both at national level and at international level. Thank you very much.
Bardzo dziękujemy za...
Thank you very much for your presentation. Before we move on, I invite to the stage the president of the Warsaw School of Economics. I need to correct myself, my faux pas. I wish to welcome 2 of our guests. The president of the Warsaw Medical University, Warsaw, welcome. And my warm welcome to the president of the Physical Education University, Professor Bartłomiej Molik. Forgive me for not mentioning you earlier. Welcome. Ladies and gentlemen, let's move on. We have a lot on our agenda today. Deputy Dean of Warsaw School of Economics, Agnieszka Chłoń-Dominczak. She'll tell us about the health and economic activity of people over 50 years of age in Poland and in Europe. Good morning. I'm very happy to see you here in our Congress, and I'm happy that we have online participants as well. This is a great opportunity to share knowledge and exchange the results of various research studies. Apart from my function, I have the pleasure to lead the SHARE project, which is the project of survey of health, aging and retirement in the EU. I would like to tell you a bit about the results of that survey. This is in the context of the interrelations between the health and economic activity, particularly in the period around the retirement. As we heard from Francesca Colombo, throughout the whole life, those two areas intertwined. Our health is visible in the way how active we are in professional terms at the end of our lives. But before I move on to telling you about the details, let me mention that a lot of the points that were addressed in the previous presentations affect us as individuals, as people who work in scientific settings. The data that is collected in administrative settings and databases face serious challenges throughout the countries and public administrations. That includes Ministry of Health, Ministry of Digitalization, of Labor and Social Policy. And together with the University of Warsaw, we try to have a better application of the data that we collect, and I hope we will finally be able to obtain that goal. Now let's move on to my presentation, please. Aging of the population has been mentioned as a clear megatrend in Europe. What it means is that we have an increasing number of elderly people and people who are 50 plus who are professionally active. At the same time, in this group, we see that the health condition worsens relatively quickly. German scientists have shown clearly that it is the age factor and not the health factor rather than the age factor was more determinant of the capacity of people to remain professionally active. That is why we need to understand what to do to remain in the best possible health as long as it's possible. That is one of the areas that is covered in the SHARE survey. It's called Survey of Health, Aging and Retirement in Europe. The research was initiated 20 years ago. It has been carried out from 2004, when 12 countries and 30,000 respondents took part in the first round of the study. In 2017, we had 27 countries already, with 77,000 respondents. Poland joined the SHARE in the second round. We participated in all of the rounds apart from the fifth one. We have currently around 5,000 respondents, and these are the panel respondents mainly. What it means is that we address them every 2 years with a survey. We've had 9 rounds of the survey so far. 2 of them, additional ones, were carried out during the pandemic, and they were done on the telephone. So we study aging as a multi-dimensional phenomena. Our analysis encompasses various aspects, and I will focus on the ones that pertain to the health condition and professional activity. Let's compare how people 50 plus evaluated their own health condition throughout the years, starting from 2007 to 2020. This is a subjective assessment, and let's notice that particularly in the younger group of those respondents, that is between 50 and 70 years of age, we can see an improvement. So share of people who considered their health to be satisfactory rose. Of course, the older people are, they consider their health below good more often. People diagnosed with chronic diseases do not note improvement. This rate of improvement is not significant in people of 80 plus years of age, where they have more chronic diseases diagnosed. We may conclude that during nearly a decade of the survey, and this is pre-pandemic, the health condition of Polish citizens in terms of chronic diseases did not improve much.
In looking at the pre-pandemic data, because the pandemic has changed a lot when it comes to the picture of the labor market, it makes sense to pay attention to the fact that in Poland we have to deal with a greater labor passivity at the retirement age. That's to say, for women at the age of 60, and in men 65. And here we have the professional activity, both for males and females. The professional activity indices are lower, especially for females, which is also connected with the lower retirement age that applies in Poland. However, if we take into account the various indices for health care, and here we have the self-assessment of health condition, to what extent, and it's also in function of how many measures can be applied in terms of the incidence of chronic diseases as well as symptoms of depression. Here we can see that in people who are professionally active, we have a rarer situation of declaring a situation that would be worse or limitations to professional activity. In females, however, if we take a look at this, the health condition is worst assessed by people who don't work and are not retired, i.e. those who, for various reasons, don't benefit from any retirement benefits, but their self-assessment of health is worse. In some cases, those differences are not that significant if we compare Poland to other countries. However, you can see them very clearly here. In the case of males, also jobless people declare a worse condition of health, both in the case of self-assessment as well as the incidence of chronic diseases as well as various mobility constraints. In 2020, we also surveyed the respondents of SHARE whether in conjunction with their health condition they have any limitations to performing paid jobs. And here we have age groups compared per age cohorts, 5-year cohorts, from 55 to 75. And here we have a juxtaposition of Poland versus other countries. You can clearly see that as of the age of 60, Poles declare that those constraints impact their ability to perform a job than in other countries that participate in these countries. So this connection between health and economic activity is very much visible. Owing to the time constraints, let me only present the results very briefly that we achieved during the pandemic as regards to professional activity. In all the countries, contrary to what we observed, a great proportion of people, especially in our region, CEE, performed work under conditions that were close to what they had pre-pandemic. However, some people were more exposed to shorter work, or the loss of employment. Some of them lost employment as soon as the pandemic struck. What's more, if there was a greater number of infections with SARS-CoV-2, also more people belong to the risk group connected with shorter work and job loss. However, the loss of employment also contributed to the deterioration of health, including mental health. And as you can see in polls, the deterioration of health and mental health, physical and mental health, was much higher than in other European countries. The conclusions: the health condition and labor market status are interconnected, and actually over the two decades, the last 2 decades where we've been performing the share in Poland, you can see that the improvement of health condition is not that good, especially when it comes to the incidence of chronic diseases, a little bit more on the self-assessment scales, and Poles at the retirement age declare and perceive health problems more frequently than in other EU member states, which of course determines their possibility of their activation and maintaining their activity in the labor market, which is natural in the face of the aging of societies. The pandemic did not make the matters better, and this is a huge challenge for economic and health-related policies. Thank you very much. Thank you very much, Madam Professor, but also please stay with us because we're in for a session, Polish Health 2.0 project, and I'd like to also invite Professor Bolesław Samoliński of the Warsaw University of Medicine, who will present the results of the survey that are needed to strengthen the health system. And since there will be 4 presentations, please observe the time, that the schedule is tight. So over to you. Thank you very much. May I invite Professor Samoliński to present the participants of our panel. Thank you very much. It's a great event that we should start talking about the connection between economy and health, and we salute to you, to Professor Hausner and the Warsaw School of Economics, because we can see it definitely. And the pandemic made it crystal clear. Never in the history of humanity was that link so clearly visible. Now we are convinced that we also have to pay attention to health in this way via economic activity. This topic is very interesting for the committee members of the Polish Academy of Sciences, hence the session. These are people who are on the presidium of that Public Health Committee of the Polish Academy of Sciences, that throughout the pandemic period clearly stated their opinions, followed the trends, and ultimately prepared a very important document, which is Health 2.0, where we touch upon the paradigm that has applied so much in public health, whether it's still valid, and if not, which way should it evolve. I believe that this will be the main content of today's presentations. First of all, I'd like to invite Professor Hanke, who is the head of the presidium of that committee at the Polish Academy of Sciences. Please join us on the stage. Professor Tomasz Zdrojewski, who used to chair that committee for 2 terms and who's the deputy chair of the Gdańsk University of Medicine. Also, please join us, Professor. Professor Cezary Włodarczyk, who's our spiritus movens engine in these matters. Please join us. And also Professor Wojtyniak, Deputy Director at the National Public Health Institute, is very important to us, an outstanding expert. And ladies and gentlemen, the last person from that committee is my modest self. I'm also present here, and I'll try to add something from me to whatever my colleagues have said. The next person to participate in our debate is Madam Professor Barbara Więckowska of the Warsaw School of Economics. Please join us, Madam Professor. And Professor Adam Witkowski, head of the Cardiology and Intervention Angiology Clinic at the National Institute of Cardiology in Warsaw. Please join us, Professor. And I'll give the floor over to Professor Zdrojewski and Professor Wojtyniak. The genesis of Project Polish Health 2.0. Why do we need to change the paradigm in the health policy? Ladies and gentlemen, if I may ask you for the first slide of the presentation, along with Professor Wojtyniak, I have the pleasure of representing public health. And I'd like to tell you that we have a mandate for that, because in one of the most important publications assessing the health condition of Poles over the 15 years of the transformation that we published at the British Medical Journal on a good model, along with the authors of the impact model, such factors that determine it on the scale from 1 to 60%. That's the key of talking about health in Poland. The second part of our mandate stems from this beautiful image. Among those 27 experts, 3 come from the small town of Sopot. That's Mr. Karnowski, Mayor Karnowski, Professor Zdrojewski, and yours truly. The doctors are doctors of economics, and I'm quite older than them, and I was born in Gdańsk. And the data show that that the residents of Sopot live longer than, for instance, men in Piotrków. Also, females from Sopot live 4 years longer than, for instance, in Chorzów. It doesn't stem from nowhere, but I'd like to tell you that another mandate is derived from the activity of the health program that we launched in 1999, and it has been going on ever since without any pause as a continuing long-term project that we started with the Speaker of the Polish Parliament, Płażyński, on older people, 60 plus. Right now it is focused mostly on junior people, and this project has been evolving after the pandemic. We decided to also add the examination of eyesight in children that arose especially after the pandemic. Let me now go back to the debate that we organized 10 years ago with the then head of the Polish Academy of Sciences, Professor Kleiberg, at the Staszic Palace, with the representatives of the healthcare organizations. And Zuzanna Jakab presented 8 key problems that still apply. People live longer, have fewer children, we have migration, the problem of contagious diseases, but she also indicated that contagious diseases have a greater effect and the healthcare systems are outdated. And clearly, we have to say that the healthcare expenditure grows a lot, so it's a matter of cost as a capex, actually. And she also indicated that in the richest countries, the number of analyses connected with health and economy is significant, and it significantly impacts the policies adopted, and the poorer the country, the fewer such analyses. And unfortunately, we have to also relate to the last 20 years in our country. The main slide that presents the genesis of our activities gets back to in 2014-15, when the standardized demise factors in Poland for over 30 years reduced significantly. The rate of that process came to a plateau, actually, in 2014-15. Well, of course, we should say we should be talking about a health crisis because that's the most important parameter of public health. If we relate it to the life expectancy of males in the Netherlands versus Poland, the difference is 7 years. That's a huge difference. Right before the pandemic, here we have the impact of cardiovascular diseases where we should make up for the gap versus the Dutch. The application of risk factors in Poland stands behind this greater incidence owing to heart attack and stroke than in, for instance, the Netherlands or Denmark. That's why Professor Strzelecki and the RL Council stated that it requires the change of the paradigm of thinking in terms of public health and public health policy from the central government. That's the main problem that was named, however, which has been triggered in Poland and has not been counteracted enough. That's to reduce the risk factors of cardiac infarction or strokes. To shift it, well, we could have matched Finland in terms of life expectancy in the 1970s. However, in the 80s and 90s, we had a huge regress in Poland because since then, the lag of our health-related factors, probably also in other terms, is of 10, 15, 20 years. Whereas in Poland has been stopped recently, also in Europe, Australia and the US, this process is also going on. However, there is still a gap to make up for. However, we're not doing that. What's more, and that's Professor Hausner's idea and the idea of this Congress, in Poland there are not enough means and not enough analyses. Why? Australia and many European countries have taken on various analyses that have identified the fact why the improvement of public health has come to a plateau recently. The pandemic had a huge toll. I needn't explain that. However, the experts indicate the secondary as well as tertiary impact of that. These are the socio-economic aspects resulting from the pandemic. Whether these data really apply and whether that delay has triggered any losses, mind you, on the right-hand side, over the last months of 2022, there are 500 deaths higher than the average from the period prior to the pandemic. This process keeps going on. That's why the key problem of lack of cohesion in the healthcare system, insufficient means, pressure on hospital care, lack of flexibility of the system's elasticity, and the double pandemic. These are problems that we have to face. As I was instructed by Minister Maciej Grabowski, we need to model them well enough to persuade the Minister of Finance that it makes sense to invest into the improvement of the health condition of Poles. And here we have what the world needs is the strategy for health is a new strategy for health investments. Well, can you explain what global output means? Because it had reduced by 3.5%, and now, well, there have to be some losses involved to the economy. This work is derived from Australia and New Zealand, and it must necessarily imply the impact for the system. So the most important factors is the health crisis since 2014, the pandemic that aggravated that crisis, the so-called health debt after the pandemic, and well, you know what it's about. The applies starting with the governance through culture and social matters is key. That's why we've taken on drafting the most important scenarios in the electoral period, so that the packages that politicians like should be filled with some content, trying to copy some solutions that were developed by Americans, in thanking them also for the significant support of the project, where we have these factors like the senior policy represented by Mr. Grodzicki, and several other chapters that we will be presenting through innovation, where the head of cardiology will be presented by Mr. Witkowski. And I'd like to thank Professor Zbigniew Gaciąg in the also public health, to Professor Molik. This is all going on in the media. This project has been quite vocal in the media, and to wrap up, I can only indicate to Professor Jerzy Hausner that there's no need to worry about the materials for the second Congress, because we have just published this work. Professor Molik and the Warsaw School of Economic experts can provide you with a lot of data for public health and the impact of physical activity on it. And we can also indicate very important data for senior policy and retirement policy, because these are very important data delivered by Professor Wojtyniak. We only have 2 years after the years of 65, so we should also factor it in while applying a certain senior policy. Professor, there will be a time for discussion and to develop that topic. Thank you very much.
That's exactly the moment when I wanted to end. Thank you for your attention. There are microphones on the tables as well, so you may use them as well. I invite Professor Włodarczyk and Professor Hanke to present the matter of the public health in the project of Polish Health 2.0. Professor, the clock is ticking. It's visible on your screen. Thank you very much. Well, despite of the tight agenda, let me start with a sentimental memory. It was in 1997 when I went last time to the library of this school, and I was collecting materials for my PhD thesis. Since that time, I haven't been there, but I still worked on some economic aspects of the public health. That is the title of what I want to share with you. This is the structure of my presentation. What is the genesis of this attempt to address the matter and elaborate a project that we might consider to be fit to improve a situation of a deep crisis that we've heard about in all previous presentations and addresses? COVID uncovered a dramatic vulnerability of the system, both the healthcare system and economic systems, and vulnerability of all of us who should be able to react and respond to that. So, since we agree that it is a crisis, it is necessary to respond in a reasonable way. That is the birthplace of an idea that Professor Zdrojewski mentioned. We drafted a document to address the most critical matters that need to be improved. We needed to react quickly, to react in a way that would provide means of responding to new challenges to public administration, healthcare professionals, and all of us. And that was, in our eyes, an opportunity for improvement. How do I operate the control, the remote? Where do I direct that? You have seen the cover of the document. It presents the team that works under the Committee of Public Health of the Polish Academy of Sciences. It's called a policy brief, basic strengthening of the public health. I need to tell you straight away, it's not the public health only that we're aiming at. It's the healthcare system, and the public health is its integral part. The policy brief is divided into 6 working areas. They illustrate key areas that present the opportunity to build improvement in the healthcare system. The first one is where we treat the health, where we look for evidence to build a strategy, that it would be an effective strategy and evidence-based. it may seem that after the scientific breakthrough of the 19th century, there are no doubts about that. But when the pandemic crisis occurred, it turned out that we, as public health, we have no scientifically confirmed actions that might turn out effective in this dramatic situation that has been unknown until then. What was accepted so far was not applicable because scientific libraries did not contain any guidelines that would be applicable in practice. Once we wanted to have effective impact on the economy, on people's health, there's thick volumes in libraries and dozens upon dozens of scientific publications with many bullet points that were useless because they didn't give us grounds for using them. We also realized that the systems should operate in an integrated way. It's not possible to separate public health from restorative medicine. Public health was not able to prevent, and restorative health was not able to treat. So at the collision of those two impossibilities convinced everybody that the system needs integration. Theoretically, we had all been in agreement, and Poland heard the position title coordinator for years and years, that was supposed to be a panacea for disintegration, but realized that the things were not the way they should have been, and it was not applicable in our actions. The third area that is of utmost importance is that we're constantly facing inequalities in health. It is a matter of fact, and it has been true for many years, that the richer ones are usually healthier. The poorer ones have worse health condition and die younger. And not even mentioning the comfort of life, which in the latter group is dramatically lower. So it has been a slogan for a long time, and it's a public health point in all the countries. But in practice, it's not visible. It hasn't been breaking through. The crisis of the pandemic showed that really clearly that people with various disabilities or underprivileged in terms of education or location where they live or any kind of discrimination, representatives of those groups had it very much harder. Next area is the social awareness. Well, when we say health education or pro-health education, is this area to shape the behavior and habits of our everyday life. How much we work, how much we rest, how do we spend our free time? Do we follow the rules that are presented by health promoters? But unfortunately, they become burdensome for us at times. Let's see it that way. A lot of the guidelines, pro-health ones, they're related to restrictions. We cannot do some things, and at the same time we are forced to things like physical activity because, it turns out that one of the most effective preventive measures against the health risks is to be physically active, particularly in nature, in the open air, let's say fresh air. At the beginning of pandemic, you remember that the authorities came to conclusions that we should not go to forests, one of the most absurd recommendations you might ever imagine. This is wrong information policy. In terms of pandemic, we were all afraid. We were anxious for ourselves, for our loved ones. We were afraid of economic collapse in a situation where our society fails in everyday functioning. So the authorities, the experts, they were communicating among themselves, and then they communicated it down to us. That was in conflict with the basic principle of public health. And then the last issue, who delivers the knowledge? Suddenly it turned out that the experts weren't more than just a decoration in conferences, whereas the politicians present decisions that they had already made. I'm sure you saw the transmission of President Trump, where Dr. Fauci was in the background trying to find a moment to say something, but usually he didn't find any slot of time to just kick in and say. So we need an expert support that is competent, well organized, and heard. This is a requirement.
Pan profesor Czarek Wodarczyk to jest mój mentor. To jest pan profesor Wodarczyk.
Professor Wodarczyk is my mentor in the Institute of Labor Medicine. We met. So, ladies and gentlemen, I'm not able to operate this remote. Well, in our discussion, we will go back to those matters that are the current ones. And we saw that the epidemic which we went through had a fallout and left us with urgent problems. Thank you very much. Let's move on. Let me invite Professor Barbara Więczkowska, who represents our Warsaw School of Economics. She'll tell us about the economic matters in health, how to finance health, amongst others, and other aspects. Barbara is an outstanding expert on health, and over to you. Good morning, ladies and gentlemen. I'm happy to be able to present the results of the work of our team. Let's have the presentation, please. There it is. I represent the team of Rudawska, Sowada, Węgrzyn, Wierzba, Więckowska. We made an attempt to respond of how to find additional sources and mechanisms of financing healthcare systems. Let's hear this. Just like Professor Wodarczyk said, we had a task. We prepared policy brief. It is a tool based on evidence about the efficiency of solutions that are in other countries. And we do not need to copy them and paste them into our system, but we saw what worked and we tried recommending that to our experts. Obviously, this is the period when perhaps politicians may listen to solutions that worked out somewhere else, and it's not only the political power that would determine decision makers. The demographic challenges are really huge. This is both on the expenditures and on income sides. Apart from that, the healthcare systems is an extreme shortage of financing. In the EU countries, public expenditures per capita compared to the Polish ones, or when only Greece and Latvia have lower rates, other countries have higher ones. In terms of international indices like your consumer index is really negatively assessed by experts and users. We have not enough money, but you know the money will not do the job. We need to understand that increased financing will not be enough to solve all the problems. It will help, but as the result of review literature, we presented 5 recommendations for our system. I'd like to present them to you. First is to reconstruct the health contribution. The second, introduction of a separated long-term healthcare system. 3, taxing the so-called syntax. Then preparation of the recompensation by the insurer and mutual insurance. And the 5th one, using mechanism of lowering the costs of waste management. It will have a macro effect, let's not doubt that. Now, in terms of the health contribution, after many discussions, we haven't looked for any other solutions. Just leave the insurance system to the benefit of the tax one. But it is really urgent to work to have those groups that are insured without contribution. We need to tackle that. The first principle is that the person who is insured is a person for whom a contribution was paid. It doesn't mean that it's that very person paid it, but it can have other sources of financing. But the system will fail if there are insured, but the contribution is not paid. Here, I'm talking about the co-insured people, like spouses and children, where the state budget finances their healthcare services. Apart from that, the situation is that there are some exemptions, like church people. Secondly, the basis for calculating the contribution should also change. It should not only be income related, but other factors we should take into account. The farmers' contribution should be discussed again, and it should grow. So that is one part of the picture. The second recommendation is to introduce a long-term healthcare system. We have the system, but it is not separated. Well, the way it is financed is through health, social service, plus some care benefits from the social insurance fund. All of that makes it unclear who is responsible for people who are not able to function on their own. And we can see the number of those people is growing. So far, the attempts to introduce changes were not effective, and I worked with Professor Galiga in 2007, and my only task was to define how much that contribution should be. The next attempts by Augustin in 2015 failed as well. We need to remember that even when we define the financing on the basis of the funds that are spent on senior people now, would so-called free some funds from the system, because we would have less hospitalizations that can be avoided among those people, and the hospitalizations for the so-called social reasons. The next recommendation pertains to sin taxes. We keep hearing that we should talk more about other sins and taxes, not only alcohol or cigarettes, but include unhealthy diet as well. In some countries, we have really positive results. In other countries, we see what mistakes were made, for example, in Denmark. Generally, the research shows that sin taxes are relatively easily accepted in societies, but let's remember as well that the consumption of unhealthy food increases the risks, and in terms of insurance, it should be translated in higher contributions. So the sin tax is a response to a situation of people who just prefer to eat unhealthy food. That funds need to go back to the system and be spent on the healthcare services and not remain in the budget. So apart from sugar tax, we need a fat tax. Next recommendation is we need to introduce the patient co-payment scheme. Very important context is that it should be further defined, whether it's a flat rate or a fixed co-payment. Well, it can be applied depending on the purpose, or whether it's a specialist visit or dental service or diagnostic service. What is important is to avoid a situation where we actually have these catastrophic costs in healthcare, where small expenditures in household accumulate, and they make it impossible for the households to use other services. So additional insurance, like in France, could cover some of the co-payments. This solution could lower the consumption of the services that are not actually justified. And the last recommendation, which seems microeconomic one, and Professor Wierzba insisted on having that in the system, is the following.
That's the economic analysis of the law. We've been able to find one example that shows that exactly the change of funding should not only be connected with the amount of revenues or outlays. The economic analysis of a law can also help us reduce the charge upon entities. So, for instance, this relates to medical waste, and it stems from the law that the only way of disposing of them is incineration, which is a more expensive solution vis-a-vis other European states where they can be reused, and owing to this, entities can have money for different activities. So it would be good to review the law, and which could adjust it to international solutions and also reduce the costs. These are 5 solutions that I've included in our policy brief. I've been able to stick to my time frame. Thank you very much for your attention. Thank you very much, ladies and gentlemen. Our next expert, the outstanding cardiologist, head of the cardiology and intervention cardiology clinic, National Institute of Cardiology. Professor Witkowski, over to you. Thank you very much for the invitation. It's a very important congress for me because it shows the interface of the economy and health. I hardly need to persuade anyone here how key it is. I've been asked to coordinate the topic such as implementation of innovation in medicine. Here you can see all the co-authors, the entire team, and it's incumbent on me to present to you very briefly what we've written, which you can agree on or not. We talked about the health crisis which is going on in Poland, which is manifested by the lack of improvement in life expectancy, and recently, so this negative trend has been further aggravated by the COVID-19 pandemic, which caused the arising of the health debt. I won't develop on that. 70% of all deaths are derived from cardiovascular diseases. Here you can see the mortality for 2020 and 21. Per the Central Statistical Office, the number of deaths in 2020 surpassed the average annual amount by 100,000, and in 2021 it surpassed the average amount by 154. Of course, the COVID has claimed its toll, but still in 2022 the predominant deaths were owing to cardiovascular diseases as well as oncological diseases. The slide was presented by Professor Zdrojewski. Let me only draw your attention to the fact that the impact of the COVID is not only direct and secondary, owing to the delayed treatment of other diseases, which we know from Poland as well as other countries, but there is also the next wave, the tertiary impact connected with socioeconomic factors. So I'm sure we will still be facing the consequences of it, but I'd like to come back to the life expectancy in Poland, which is 4 years shorter than the European average. And if we look at the deaths for reasons that could be avoided owing to prevention or medical practice, we also lag behind the EU average, and we have 62 more deaths as compared to the European average that could be avoided owing to prevention and owing to medical intervention. We have 30 deaths more. So the situation is not good. As you can see, Poland is still, according to the Polish cardiological diseases, is still among the high-risk countries. And as you can see, the 75-year-old country in a low-risk country such as Spain or France can live longer when it comes to the 10 years survival than a patient from Poland. This is, of course, connected with the huge popularity of risk factors such as hypertension, which is badly treated or even not treated in Poland, hypercholesterolemia, obesity, as well as consumption of tobacco. And, well, simple interventions, I should say, because if we talk about innovation, we think about new medicines, but innovation can also be new healthcare systems, new integration connected with the integrated patient care, and a simple program such as KOS, Zawał, or heart attack, which boils down to the fact that a person who's had a heart attack should visit the doctor and take medicine. And managed health intervention means that statistically the people affected die less frequently than those who have not entered the program. However, coming back to the definition of innovation is defined as the result of all activities with a technical, scientific, organizational, financial, commercial solutions that have led or were meant to lead to the implementation of changes for products, processes, organizational or marketing. And it shows that for healthcare, it is about the development or delivery of better solutions, technologies in healthcare. So it's just one of the components of innovation, and the services that can impact the health of people. What are the outcomes of implementing innovation in medicine? What is it all about? It's about the reduction of mortality, better control of chronic diseases, the transformation of some uncurable diseases, terminal diseases such as cancer, into chronic diseases, the improvement of the quality of life, personalization of therapy, quicker and more detailed procedures. We know that the investments into healthcare are kind of very closely connected with the health condition of the entire society. One of them is access to interventions, both medicine-based and non-medicine-based, which in Poland and in other CE countries is clearly reduced vis-à-vis the old EU countries. First of all, Spain, France, Germany, UK, and Italy. As per the recently published PwC reports and EFPIA, it stems that patients from CE countries unfortunately stand twice lower chances of obtaining innovative pharmacotherapy. And that's the report which shows that firstly, CE countries spend less on healthcare as a proportion of GDP compared to the old EU5 countries. This is 5 versus 8%. That new data from Poland for 2019 still don't show a significant increase for healthcare. Today, it is said, these are the official proclamations by the Ministry of Health, that it's between 6 and 6.5%. Independent organizations claim that it's not even 5% or almost 5%. Don't know who's right, who should be believed. However, as you can see from this graph with many curves superimposed on each other, well, we can see that we lag behind the 5 top European countries, and that below us is only Bulgaria, Romania, and Hungary. We only have 35% of new drugs that are authorized by the European Medicines Agency that are available in our part of Europe. And it takes 1 year from the issuance of an authorization by EMA for them to be implemented in CE as compared to the old European 5. And we know that if we invest in health, that's what this Congress is about, we'll have a significant return in terms of keeping the people we've cured on the labor market, and they will be paying taxes, which will be definitely healthy for the economy. In Poland, a significant source of innovation, just as globally, is the pharmaceutical industry. The Polish clinical trial market is worth around 2 billion zlotys. 98% of them are commercial and funded by the pharma industry. Non-commercial, initiated by scientists and non-for-profit, only represent 2%, whereas in the old Europe it represents 30%, which shows that changes are needed. Maybe the establishment of the Agency for Medical Research could change this situation. And also submissions by institutes, research institutes represent 48% of all the submissions to the European Patent Office. And generally, you could say that an important role is played by startups in Poland, because roughly half of the startups investigated work in the area of health, and this is hugely significant. These are, first of all, startups that work in oncology, cardiology, and radiology. We should create transparent rules for expert clinical and economic evaluation of new technologies, medical technologies, and the paths of their implementation, such as breakthrough therapy, accelerated approval, or fast track. I won't explain it all. That's why we presented a scheme of integrating the healthcare system in Poland with the implementation of innovations. That's what it looks like. In our opinion, this is quite a centralized system, which might not be appreciated by everyone. However, it seems that the implementation of innovation, such that could be used subsequently or quite quickly used in the treatment of patients, it should be pretty much controlled. It should first assume the form of a supervised register evaluating the technology and its use in Poland based on the results of per that supervised register. It would be key to preserve the agency of technical of medical technologies and agency for medical research. Of course, the ultimate decision would be made by the Ministry of Health. Of course, there are other mechanisms enabling access to innovation, such as increasing the number of patients involved in clinical trials. It's not working as well in Poland as in the West or the US. The risk factors that are applied, well, maybe an important component of this in the case of some costly therapies. It would be going for central, even EU central purchases, as well as coordinated, dedicated programs for diseases that pose the greatest risk for the society. And to wrap up, to ensure greater and quicker access of Polish patients to innovative medical technologies, it's necessary to increase the expenditure on health care in Poland. This is a truism. And also to advanced therapies, one should aim at changing the system, integrating this and implementing such institutions such as AOTIM, ABM, maybe less so Ministry of Health and the National Health Fund, which is actually the executor of the Ministry of Health. It should be, it's been reduced to that role. Should define such notions as breakthrough therapy, fast track, and accelerated approval. This should all result in the integration of the system, integration with the public health system, which has been mentioned multiple times here. On the other hand, with quicker and easier access to innovative medical technologies for the patients. Thank you very much. And now we'll invite you to the session of comments that will be started by Dr. Maciej Grabowski, who's an economist. He's been the Minister of Finance, and he knows perfectly what it looks like if the Ministry of Health, the Ministry of Labor come to the minister and say that money is needed. We've heard that money is needed. However, please present your comment from the point of view of money for whatever is needed in healthcare. Good morning, ladies and gentlemen. Thank you very much for the invitation to such an important debate. I feel a bit modest. There are people, professors here, very important people. I'm just a doctor. In preparing for this event, I've presented several remarks or theses that I'd like to share with you. But let me start with something different, triggered by what I heard, namely a thesis, or actually an example. I've also been a minister of the environment. And when we presented the first national air protection program, but when I realized what impact it has upon health, I was convinced I had to do it. However, I didn't feel any pressure from the medics, from the Ministry of Health, or at large. So I believe that this broad, holistic approach to health is by far necessary. However, that pressure, I mean, we should focus more on this, or like the Excise Act that's been implemented, and it assumed a path of the excise increasing without any point. Right now, realistically, the prices for alcohol are cheaper owing to inflation. And I didn't hear anything from the Minister of Health, because it's clear that if the excise increases, then the consumption of alcohol also decreases. I'd like to remind you of what we have experienced over the last 3 years. This is a comparison of what was happening during the pandemic. I made a comparison of such models with different countries. That's the total excessive mortality connected with the COVID versus normal mortality in gray. In France, it's actually 1-to-1. The excessive mortality was only triggered by the pandemic. And in our case, it is distributed in such a way that actually the pandemic is responsible only for half the mortality during the pandemic. In Greece, it's even less. In Italy, there was a system that was adjusted to the problem, because after the huge initial problem, the beginning of the pandemic, you remember what it was like. Actually, then we had a similar situation as in France, where the excessive mortality was only connected with the pandemic. In Hungary, we have a high excessive mortality. However, it was not triggered by non-pandemic reasons. So you could say that, well, we don't have a healthcare system as France, a greatly organized state. We don't have a system that learns and adjusts to the new situation as Italy. And actually, those phenomena that we can observe in Hungary, where excessive mortality connected with non-pandemic reasons was also not observed. And the problem I have as an economist with the recent pandemic, we say that it was a natural experiment, as the economists say, of an unprecedented scale. Actually, the process of decision-making, defining, required planning, funding, defining goals, adaptation to the ever-changing situation. It's a huge experimental material that should be analyzed if we want to think about the change to the healthcare system. And we know, well, I've taken part in many program evaluations for public programs, and those methods are well known, how it's supposed to be done. You have to assess the goal, plan, funding, what worked, what did not work, the process of preparation, the supervision, and the effects, and at the end of the day, the most important thing, the lessons learned. It's not about charging someone or accusing if they did something wrong. Mistakes can happen under such conditions, but whatever worked, whatever could have been done in a more effective and efficient way, actually we don't know. supposing another pandemic struck in a year or 5, we have no major lessons learned from whatever happened. And actually, the last important thing I cannot fail to mention was mentioned before, the medical fund of 2020, a fund that is not a fund because it doesn't have its own funds, actually. It's a non-budget instrument. It's out of the parliament's control. It's not subject to reporting. Theoretically, it was supposed to spend 4 billion over 2 years. Just 1 billion has been spent. It seems that there will be 40. That's not the way to work. That's ruining public finance and ruining and deteriorating the system. I'm not saying that the money is not needed. I'm sure it is needed. We've heard about it. And we also don't know what the methods of evaluation to be used in the assessment of infrastructural methods, whether these are methods that we are aware of, for instance, in local governments, where applications are sent to the Bank of National Economy, they take it into account, and the decisions are made in the Prime Minister's office. I hardly need explain how it's done, or at the European Investment Bank that also funds, for instance, hospitals and other institutions where the principles of multi-criteria analysis are very transparent. Maybe there are also other methods that are used there.
In the whole environment, in the economic setting, we all do not know what criteria are used to evaluate what goes in for the financing through that fund. I'm sorry for sounding a bit chaotic, and I'm not being optimistic in what I'm saying, but my point of view stems from the public financing point of view. Thank you very much. If I may just comment on that briefly as a word of introduction to our debate. We still have time, so there's a window open for our debate. When we speak of a public debt, I really don't like that wording, and I don't understand it. Pardon, not public, but health debt. I don't really know who owns what to whom and for what reason. But let's leave that to the side. I tried to see what economy and law says about the debt. So in the building of this school, let's think about also whether this terminology is applicable to the matter that's as important as health. The death rate in Poland reached 200,000 people, and 120 people or deaths is a documented increased mortality due to COVID-19. People who died and had a positive COVID-19 test. Among the 120,000 reasons, if somebody died for another reason, was also included in that group if the COVID-19 test was positive. So the cause of death was not directly the COVID-19, what Professor also mentioned. So two words, so to speak, seem to collide now, and I'm happy to hear an address by a representative of the Ministry of Finance. The medical environment seems to consider the Ministry of Finance as the main blocking factor of growth in healthcare. When we discuss the financing, and in the Congress of the Health Challenges, we heard a thesis that was clearly defined. Currently, the state and our healthcare system, stemming from lack of financing healthcare professionals, is that we do not need to increase the spending up to 7% of the GDP, but we need to double financing to stop the healthcare system from degrading. So we entered a gigantic pandemic that developed in Poland when we were unprepared in terms of the healthcare professionals. In Spain or in Italy, where initial death rate was dramatic and they were not prepared, improved because they had reserves in their systems, and we haven't had any stuff on the reserves for many, many years. So the shortage is not only in terms of the money, but in nurses and doctors' numbers. There's this convention that we pay fee for service, and it's failing. So the patient is like an object in that system. We do not pay for a medical result, but for a service itself. And that is one of the huge problems that needs addressing. So in that experiment of financing healthcare system, we can see it's failing. Not only do we have too few centers, but according to OECD, we have too many visits per patient. But according to OECD, we're in leadership in the number of visits per patient when we have the staffing shortage. So when the pandemic started, we had no financing or staff or equipment reserves. We had organizational problems. My personal opinion is that Poland really succeeded, and the fact that until June 2020 we didn't have the epidemic wave. There was no second wave as everywhere in the world. For us, it was the first wave in June 2020. Why? It was due to a very traditional system of fighting epidemics that has been used for 1,000 years. Protect oneself from any contacts with infected people. Personally, I agree that a ban on going to forests or parks was not a good solution, but all other measures turned out to be very effective. Ladies and gentlemen, what happened then? Now, from the point of view what we saw in the healthcare system and economic consequences, what happened was children went to school. So that was a vector of disseminating infections. In the autumn, there was a real explosion, the first wave, then in spring, the following year, the next wave. As Professor Witkowski mentioned, we stopped epidemic using innovations. That was vaccine. Unbelievable and unique innovation when we introduced an entirely new way of combating the virus. A mRNA vaccine, so-called vaccine, was produced. It is actually a form of intervening at the genetical level, the protein-based intervention in the human organism. Well, we produced the vaccine within our own bodies. That's an extraordinary event. Now we're ending that period and starting the new one. What happened? Well, unfortunately, what happened needs to be debated now. So that is why we're adding some more time to that. We forgot about all terrible things that epidemic showed about our system. Let me remind you that Poland knows very well things of public health, such as prevention of civilizational diseases, without any successes in that field. We drink 3 liters of pure alcohol more than 10 years before. We stopped the decrease decreasing trend of smoking in the general population, and it's increasing in young people. We have terrible epidemic of obesity and overweight. 3/4 of senior population are obese or overweight. Apart from that, there's a problem of physical activity, which are the main factors of influencing civilizational diseases, and sooner or later, that will be visible in the statistics. Now, I'd like to encourage our colleagues that haven't presented so far. Professor Hanke and Professor Wojtyniak. Gentlemen, can you please give us your comments about what you really are experts on? Professor Hanke was a national consultant on environmental health, and Professor Wojtyniak is outstanding expert on epidemiology and demographics. Can we start with you, Bogdan, please? Because we heard this slogan, let's talk about that. The population is aging. We have staff shortages, payment shortages in the healthcare system. So what perspective can you see? Thank you very much for your kind word when you introduced me. Ladies and gentlemen, the situation is really interesting. It has been for many years that the experts on demography has been saying we live longer, and that is a success and not a threat. Let's say that clearly. Stop thinking about us living longer as a catastrophe. That's an achievement of medicine, and that's an achievement of the social development. A large article was published in Lancet, which is the main medical journal, that discussed that topic. Let's stop seeing that as evil, but as a real beneficial factor. The number of elderly or senior people is growing. The only problem is, let's have these people in the best possible health. When somebody is 80 years old, it does not mean that they need to be bedridden. They need to be still active. It needs to be taken care of well in advance, and we need a system that is prepared to do so. It seems to me that this is what we need in terms of our way of thinking. Senior people should be as active as possible and as healthy as possible. Can we obtain that? That's a really interesting aspect in our recent analysis results, and we haven't published them yet. They show that there is this harvesting effect. What it means is sick people died sooner due to the pandemic. And now in 2023, the death rate is lower than we would expect. We haven't published that anywhere yet. So now the most sick individuals are now out of the total number of the population in Poland. We will have relatively less number of really sick people in the system now. So now the system will have to deal with, let's say, like less sick people, or will the COVID-19 made people who did not die become sicker, so that their health deteriorated due to COVID-19, although they did not die. So we need to balance out which factor plays a bigger role. We need much more analysis. Thank you very much, Professor Hanke. There are climate changes. There's a problem of clean air or polluted air in our country. That is a very important factor. it is responsible for 50,000 preterm deaths. Climate changes will have really worrying effects on the population. We may expect migrations and vector diseases that will result from that. Thank you for your question. Polluted air is a problem that disappeared from our agenda, ladies and gentlemen. Why is that the case? We expected a harsh winter when the coal would save us. On the other hand, we do not want coal anymore because it is responsible for the pollution of air generated by individual households and ovens in them. What we have as a result of that is a problem what to do next. The European Union offered to lower the standards by far. It's not a WHO standards that we may accept or not. These are EU standards that challenge our capabilities in a serious way. So how to reconcile those aspects to provide for the need of warmth, to keep us warm, to combine it with the fact that a better fuel costs more. And the context is that the whole world is aware of the fact that polluted air is a quiet killer that kills the weakest, those who have chronic pulmonary diseases, asthma. The death caused by polluted air is also visible in the cardiovascular death rate. So this is all related to lifestyle, and that is a problem that really needs addressing, in my opinion. The team for air pollution and health suggested some solutions, and that's the team that works under the Ministry of Health. And they suggested some plans to lower the limits in Poland. We propose this solution to be real, effective, and planned over time. In terms of climate, well, we've seen that on our agendas for some time already, but we do not see that in people's awareness. We enjoy warm weather outside when we can go to a restaurant and take a table outside. We really like the Italian style of living, so to speak. It does not translate to our understanding of climate changes. What do they mean? It's a serious change of ecosystem. The ecosystem that we have is in a certain balance, and it may face a sudden collapse. We may have the diseases suddenly occurring here that hadn't been seen before and affect us. The temperature rising, it doesn't mean that we will have a mild and warm weather. We may have heat waves and sudden abnormal weather phenomena with serious consequences. What to do? This is strictly related to the first topic. We need to give up on fossil fuels, although it is really difficult today. And I'd say policy-wise and social-wise, it's difficult to accept the solution now.
Thank you very much, Professor. We'll start a Q&A session from the attendees. Let me just take advantage of the fact that that I'm moderating this part to comment on the society aging and the changes involved. I absolutely subscribe to what the professor has said as a demographist, and the very process that we should be living longer is an achievement. The fact that fewer children are being more is not a success story, and it definitely contributes to the society aging. The problem about the society's aging is that we don't invest enough in what's important, into the human capital. This is also an issue that became patent during the pandemic, and this is something that we will be also facing in conjunction with combating the pandemic, and we'll be facing it for a long time. As Professor Samolinsky has said, the fact that we implemented a very strong lockdown at the beginning, that children did not go to school, certainly contributed to the fact that the pandemic did not develop at the first stage. We had smaller incidents. Unfortunately, we can observe the results in youth. The fact that the pandemic also added another year to the education system, plus the reform, which means that many young people have to catch up with and make up for the problems. The fact that social contacts were limited, the possibility of functioning, communicating in traditional networks also means many mental problems that young people face. Roughly 30% of children and young people face various psychological problems. The mental and psychological health of youth and children is one of the problems which is quite visible in what we have been discussing. It's hard not to agree with what you are saying, but mind you that we had a 0-1 system of responding to the pandemic in education. Let them go to school or not, like as though there were no other models, and where children could just stay in some controlled environments with a minimum risk of transmission. For instance, nothing like a group isolation was applied. You only thought about individual isolation, and group isolation in education would be critical. You should not allow several groups or several classes at the time into the same locker room or into the same dining room. Schoolmasters did not have a clue. And someone should have responded. And you can clearly evaluate the economic aftermaths. Well, we had to deal with a lockdown which resulted in bankruptcies and the costs for the environment. The connection between health and the economy was very clear during the pandemic. And if we're talking about the demographic changes, I mean that if we have fewer and fewer children, more and more aged people, and without making sure that that old age should be spent in good health, and the fact that the cost consumption for that group is very high, but that's not the only cost. The cost that also arises is connected with disability, and it also relates to other groups. Each disabled group is cost intensive for the system. If the healthcare system and the disease prevention system does not make sure that we have a healthy population, we will have additional costs involved with the fact that the population is not healthy. If we imagine, well, let me just stop. We had plenty opportunities to say something. Let's give the attendees an opportunity. Let me just wrap up in one sentence. This is very important. That's the perspective that we need to understand. If the demographic coefficient keeps growing. The number of people non-working to those working keeps growing. And the accumulation of old people with disability we'll face an economic crisis. Do you agree? Yes, absolutely. That's why I was talking about the necessity to take actions to ensure longer periods of professional activity, especially in the period around the retirement, hence the Congress. And I'd like to invite you, ladies and gentlemen, to say something. We still have a moment for a discussion. How Polish Health 2.0 and what priorities do you perceive in terms of health, economy, and activity? Whoever would like to say, I think we can pass the mic, as I understand. Wojciech Cyrul, I'm the director of the University Hospital for Children in Krakow. It's one of the largest pediatric hospitals in Poland, and I have been listening to the discussions with a lot of attention. And first of all, thank you for inviting me, and thank you also for presenting it in such a nice way to us. However, there is a couple of things that have worried me, and I'd like to share it. First of all, I don't know if you've heard, but our panelists only mentioned children twice over the 2 hours. That the problem of low number of children was only mentioned twice. The rest of the discussion was devoted to people who leave the labor market. That's the retirees. And the scary fact when the professor mentioned the shift of the costs, and he said that retirees are 3 times more expensive than the other groups. Well, from the perspective of a director of a pediatric hospital, let me tell you that the most expensive patients are children, and there's the fewest, or actually the smallest number of funding is devoted to them, because we focus on treating old people. And I think the title of the Congress is wrong. It should be Congress Economy and Public Health, because health is a different thing. The problem of health is the problem of suffering and opportunities to live a dignified life. If we don't think about children from the first moments of their lives to ensure safety, care to them, access to innovative therapies, otherwise it doesn't make sense to talk about retired people, about the economy and the future, because we waste the future. We lose it at the very beginning. I'd like for this to resound, because I talked to ministers of health and the heads of the National Health Fund. On the other hand, with teachers, university teachers. I'm a professor of and a doctor of laws also. Although I've been managing hospitals for years, and in such talks, what I miss are human faces. We talk about law, but we don't see the human being. So it would make sense to see the old lady in our office, the young child who cannot be administered some medicine because it's so expensive, or we administer absurdly expensive medicines. The example is of Zolgensma, 9 million zlotys per child. You know how many children you could treat for 9 million zlotys? 20,000. The same amount that the state has provided to a single child. Maybe that's great, but why so little to all the others? Thank you. Thank you very much. Anyone else? Professor Hausner? No. Good afternoon, ladies and gentlemen. Thank you very much for the opportunity to share my thoughts with you. I believe that most of you, I'm sure, all of you are outstanding scientists, and I'm aware of your scientific work. My question is, how do you evaluate, as we are here in Gremio, what sort of all achievements, scientific achievements, that are often applied, to what extent are they implemented? Implemented not by those who create science, which is very important, but those who execute various activities that should stem from science. It seems to me, although I may be wrong, I agree with the professor that the theory of learning is only transformed into practice in a very limited way. Secondly, what relates to environmental threats, and it's very good that this point should have been raised here. However, in a way, we have an impact on making sure that 60 or 50,000 people should not die in Poland owing to chemical contamination of the environment, which means that science is not being heard by people who apply such things, and in my opinion, especially in this period. Secondly, over the last couple of years, a great number of scientific centers have been impoverished or largely closed down, which by and large refers to the Institute of Food and Nutrition, whose scientific potential has actually vanished by half, and by being implemented into the National Institute of Hygiene. And actually here in front of me, I have a document that I'd like to submit to you, Madam Professor. Unfortunately, we cannot hear the comment because the speaker is holding the mic too far away from his mouth. And I wish to convey the message. Oh, I'm sorry, says the speaker, but there's one more, Professor, and one more paper which says who the person is, who the author is. And the last thing that I want to share with you, I'm very happy that you should be organizing this conference and this program that we have here, because there are few institutions in Poland, in my conviction, that would like to deal with this. Thank you very much. Thank you very much, Professor, for the materials and comments and all your words. As I understand, Professor Nowak wanted to say, but please be very brief, because it's the time for a break and networking. I don't have a comment, I have a question, because I deal with fiscal policy, tax policy among others, which, as you know, shapes some habits in people that support health or otherwise. I mostly refer to the consumption of alcohol and tobacco. So my question to all the panelists is, how do you evaluate the policy of our state, also in the context of threats connected with inflation, where we can see that those indices are not adjusted to making sure that people should be discouraged from consuming whatever is harmful to them? Who's supposed to take that question? It's a very important question. I'm not sure if we should answer it now or informally. Maybe let's have virtually 15 minutes, 15-second statements, and we'll close it down because we're pressed for time. Professor Wojtyniak? Well, indeed, alcohol is too easily available, and definitely prices should be increased. During the pandemic, we observed a significant increase in mortality for reasons directly attributable to the consumption of alcohol. So you could see that there was this mechanism of abusing alcohol, escaping into alcohol. That is a problem. Likewise for tobacco, there's a huge discussion countrywide, or globally actually, on electronic products versus traditional products. And here I must say, I don't want to share my own opinion, but I believe that as a substitute of leaving the bad habit or alleviating some aftermath of giving up the habit can be useful. However, the access to them, to the youth, is too easy. And when it comes to smoking, the U.S. Experience shows that this is a method of reducing bad results. And Professor, a quick comment, very briefly, because we assume that demand is elastic. It's not. Well, 10% increase in excise means 4 to 5 times reduction in consumption. It's not something that would reduce the consumption, but the profits should be reinvested. That's what you said. That's the economic comment. I couldn't do it any briefer. As a physician, I can say, from the medical point of view, that the aging society that Professor Wojtyniak said is a huge success of medicine. And the progression in life, that's true, or progress in life, but it also it generates treatment, cost of treatment, because a 65-year-old patient is not the same as a 90-year-old patient. There's huge morbidity, and we should be prepared to investing into healthcare if we want to have not only old people, but also people in good health and leaving the labor market as late as possible. We know that everybody would like to leave the labor market as soon as possible. For what you can see in France, we must invest in health, and we're talking about much higher expenditure, because old people suffer from a whole range of diseases. We have to realize that. I'd like to thank everyone.
Thank you to all the team and everybody who contributed to the preparation of the project Health 2.0. We have foreseen a chapter about children in policy brief. What you saw here is just a section. So please don't worry, it is quite the reverse in the balance of what we are talking about. Policy on alcohol and cigarettes has been covered already, and the most important Polish mass media channels undertook this debate with us together. Of course, it is in the context of the political elections that are upcoming. I hope that in the next events of this kind, we'll catch up and speak more about that. Thank you, ladies and gentlemen. I'd like to pay your attention to this, awareness of the factors that may be pro-health or may be detrimental to health. Let me remind you that one of the biggest waves of the social protests in France in the recent years, in France, where the society seemed to be relatively reasonable, so to speak, well, the reason for the protest was the excise tax. Diesel fuel. A large part of French people commuted to work in diesels, and it turned out that it will be much more burdensome on the budget. And what happened, there was a movement of yellow jackets, and it paralyzed France for several weeks. Currently, the French spirit went towards the laziness, which is working not longer than until 62 years of age. That is a mental barrier again that fuels the activities that will then be unfavorable for health. We need to do something about that. Thank you. I am the doctor that specializes in labor medicine, among others. And the way I look at it is to see the potential in people who are working currently. And I look at the staff of the healthcare professionals. There are very serious problems resulting from the fact that mental diseases, the so-called professional burnout, is increasingly frequent in that group. Young doctors don't want to be the doctors anymore who go to the front lines, so to speak. They perform surgeries. They spend time in those performance-based surgical conditions. They rather look for a quiet place of work. So that context contributes to the crisis in healthcare. We have the crisis of a health condition in healthcare professionals. Yes, there are many phases of the crisis. Let's hope that next Congresses will bring more clarity to that. Thank you very much for having presented selected aspects of the project Polish Health 2.0. We will be following the work that you do and how the politicians will take what we, the scientists, elaborate on. And we want to see how it translates into the practicalities. As a person who deals with political sciences, I realize that we need a large improvement in cooperation. Let's hope that this kind of dialogue that we initiated today and more events like that will enable us to have our conclusions included in what's becoming a reality. Let's take a break and then come back to next panels. I thank all the professors, ladies and gentlemen, and people who are online. We'll be back at 1:10. Let's have lunch downstairs. See you there.
To jeszcze raz. O, tym razem będzie ok. Szanowni Państwo, witamy ponownie.
Ladies and gentlemen, we are resuming our debate in the first Congress. We welcome the online participants and the ones here on site in the Warsaw School of Economics. Let me remind you that Warsaw School of Economics, the capital city of Warsaw, and the Foundation of Economy and Public Administration are the organizers under the Open Eyes Economy Summit. Our partners include Radio Z, Business and Architecture. Main media partner is wyborcza.pl. Ladies and gentlemen, let's hear the first session after the break. The value of health and building resilience through sustainable investments. And we will hear about various initiatives that contribute to improvement of the quality of life and health of citizens, and they are in line with the reform and reconstruction strategies. International speakers will tell us about the benefits of investing into healthcare, education, environmental protections, and we will hear about challenges that the politicians are facing in terms of sustainable investing. Ladies and gentlemen, the moderator is Professor Mariusz Gujski, Dean of the Warsaw Medical University, Department of Science about Health, and the participants include Federico Gerardo de Cosio, global expert of the WHO, Dorota Sienkiewicz, policy manager at EuroHealth.net, and Elia Diaz, director for intervention and preventive programs of the Public Health Agency in Barcelona. Thank you very much. I'm really grateful that you have just performed a lot of the tasks that I was supposed to do, so thank you for that. So now that, ladies and gentlemen, the panelists have been introduced, it is my pleasure to welcome you on this session. I owe you some explanation. When you saw the program and you read the title of this session, The Value of Health and Building Resilience Through Sustainable Investment in Initiatives under the Reform and Reconstruction Strategy, it may not be very clear to everyone of what we're going to talk about. We will be talking about a clear and important thing: the influence of the decisions that we take in the healthcare system, central, regional, local ones. So the way we perform public health and health policy, what impact it has on the way the economies function and we function in them. What is the impact of health policy on economic growth and social development? That's important. I am grateful to the originators and creators of the Congress Health and Economy. Many among us, doctors, realize how strong that connection is and how underestimated it is, how politicians need to be reminded, them who are responsible for politics and structure, the economy and society. That's crucial. This panel is a special one. Our speakers will present their presentations, and we will definitely have less time in the panel for the debate and questions and answers. Let me invite Dorota Sienkiewicz to take the floor as the first one. She came from Brussels, and she's from EuroHealth.net, where she deals with the health policy. Thank you. Let me just introduce myself in Polish. I will present the presentation in English.
And thank you all very much for making your time to come and listen. And also, I would like to thank the organizers for the invitation to speak at this very important Congress and this very important session, talking about the value of health and resilience building through sustainable investment. Perhaps a couple of words about EuroHealthNet. We are a European partnership for improving health, equity and well-being. We are focusing our work on influencing policy, as you can see, exchange of good practices between our members and partners, and really doing cool research. And the research is mostly funded by the EU funds. At the moment, we have about 65 member organizations, which are mostly national institutes of public health, regional health authorities, and local organizations, universities, and municipalities. We are present in 28 European countries. 23 of these are in the European Union region. Our mission, as you can see, is to improve and sustain health and reduce health inequalities. This is really the core issue for us, reducing inequalities in health status, in opportunities for good health between and within the European states. As said, we are based in Brussels, where we, as I said, monitor and shape EU policies really across a broad spectrum of the policy agenda. Oops. Let's see. Just very quickly, our work really oscillates around 5 priority areas: health equity, non-communicable diseases, climate crisis, prevention and promotion, life course approaches, and in addition, we also got engaged pretty much in the field of mental health and digital inclusion, working on the digital determinants of health, environmental determinants of health, and commercial determinants as well. I already said it. So the value of health in our economies. I wanted to focus my presentation on well-being economies models, which is a concept we've started looking into in the last several years, since 2018-19, and then we slowed down a little bit because of the pandemic. But I think now it's time to pick up and start doing what we've been doing, which is looking into recovery, building resilience of our health and social policy systems. So this particular slide really kind of presents 2 scenarios which are kind of laying ahead of us. Is it a path that we want to follow, which is business as usual, which we know already, and the evidence really bluntly and clearly shows that this is where we will end, climate crisis, environmental degradation, air pollution, rise in NCDs, and so on and so forth. Or shall we perhaps, and that would be a smarter idea, go towards shifting our mindset to systems thinking and go towards the economy that values the well-being, health, good life, happy lives of all people in our societies, and which values really equity in health. And I think the COVID, the pandemic, and all the polycrises, the overlapping crises that we face these days really make a case for looking into the systems approach to promoting health and well-being. We know the pre-existing unattended to health inequalities and poor socioeconomic determinants of health really magnified the severity of the pandemic and the crisis nowadays. And the impact was particularly severe, and we've heard it already throughout the morning. for people living in vulnerable situations that were hit hardest by the pandemic and the mitigation measures. We are seeing still long-term consequences in terms of increased poverty, educational backlogs. Some children with learning problems will perhaps never catch up, and that will affect their whole life, their employment opportunities. And that was also mentioned earlier this morning, really tremendous mental health problems, psychosocial, occupational, psychosocial health challenges, and a lot of this suffering goes invisible. So when we talk about the well-being economy models, we talk about two models. I will first focus on the first one, which was promoted or worked out around 2018-19 by the OECD and then taken up by the Finnish presidency of the Council of the EU in their Council recommendations, which really puts well-being centrally to everything that we do around social protection, healthcare, education and training, working towards gender equality, to really make sure the economic growth is inclusive, is sustainable, and is long-term. And the second model, so maybe the first one, I will say that many countries, or let's say increasing number of countries around the globe, but also in the EU, in Europe, are slowly taking up this approach and proposing strategies how to embed the economy of well-being models into the way they design policies for now and for the generations to come. The example is Finland, for example, they just recently adopted a 2030 well-being strategy, and countries like Wales, Scotland are following suit. The other model here is called donut model, that originated by work of Kate Raworth, and it really shows that we should organize our economies staying within this green kind of layer, I'd say. It should be people-centered, so based on social foundations, but also not extending or going beyond the ecological ceiling that we have to our disposal. Those two models, and many others are kind of around, have a couple of things in common. They are based on common values and principles. Number one, it is kind of preconception or the kind of realization and a narrative that the economy serves people and the planet and not the other way around. It's prevention-oriented and working upstream. So trying to kind of bottom up, based in communities, but trying to go towards reforms and steering the investments at the higher level. And it offers higher return on investment due to sustainable well-being benefits. And there are 5 kind of principles that I will try to go very quickly through. So the first one is dignity. Everyone has enough to live safe and happy lives. And it's certainly a kind of important thing to consider nowadays in the cost of living crisis, the rising cost of living crisis. It takes or encourages us to take a life course approach, so starting early with children, with very small children going through adolescence, working lives, and towards the retirement and older ages. And it really sees investments in well-being and health as a social investment, with a win-win and benefits and gains really spilling wider than what it was considered before. And there are a couple of examples from the EU level which kind of make case for that. Just 2 of them last year, actually earlier this year, a high-level group on the future of social protection and of the welfare state in the EU issued a set of 21 recommendations, and really pretty much all of them say the future, it is possible to keep the investments in the social protection, and really all of the recommendations that we looked at are also investments in good foundations for healthy, happy lives. The second principle is about nature, where we talk about a restored and safe natural world for all life. It talks about do no harm and polluter pays principles. And we can see it to a degree in a couple of strategies at the EU level that we see as with a potential for improving health and well-being. The European Green Deal, and under that, for example, farm-to-fork strategy, which talks about the sustainable food systems, for example. But of course, there is also loads about climate neutrality, energy poverty, and what's important, and I kind of heard it this morning, about the green transition, which is also done in a sustainable and socially just way, so that everybody's taken on board and not certain population groups are left behind because they cannot act on the recommendations issued, for example. Number 3 is a principle of purpose, where there's a sense of belonging and institutions that serve the common good. It's about working intersectorally, it's about joint up budgets across sectors and progress beyond GDP. And a new concept that we find interesting issue, certainly at the high, I'd say, European or national policy levels, it's negotiating a new social contract, which is a new set of policy actions that includes or really focuses or puts centrally equity impacts. So whether the new policies or the revised policies, reviewed policies impact everybody in the same way. And that takes me to the issue of fairness. So the justice is at the heart of economic systems. And it's important, the Eurobarometer from this year clearly said that 81% of EU citizens, so 8 in 10 of the EU citizens agree that income differences are too great, and they expect EU and their national governments to act on that or do more on that. It's also important, just to give you a kind of very stark example of that, 1/5, in some countries 1/4, so 25% of the children live in poverty and social exclusion. So that's clearly unacceptable. I mean, Poland is quite an exception, I have to say, still. They are worse countries than Poland. But nonetheless, it's something that has to be realized and really paid attention to. And there are also certain issues that are being done, or policies at the EU level. I just wanted to mention maybe one. The European Child Guarantee offers a set of funds or earmarking under the European Social Fund to really invest in providing a comprehensive set of policies to access essential services and access to healthcare. And that also means mental health services, health promotion, and disease preventive measures is one of these, but also decent nutrition, housing, inclusive education and care, and so on. And last but not least here, the participation principle is very important. Citizens are actively engaged in their communities and locally rooted economies. So here I really go into the regional, local levels, and I'm sure a colleague from Barcelona will talk about it to a degree. So just 4 things to realize. Participatory governance and budgets, I already talked about it. Embracing citizens' initiatives. There are plenty of interesting things going on very, very deep down. People trying, they want to be active and they want to do stuff to support and bring the services closer to the places they live. That also takes us to the issue of systems leadership. And organizing and maintaining structured channels and mechanisms for engagement and co-creation. And that was the first part of my presentation, because I have now how to get there. And with EuroHealthNet, we've been following a very interesting process, a tool that appeared at the EU level back in the noughties, I'd say, as of 2011. But now, since 2017, it got really very much more socialized. It's to be aligned with, or is aligned with, principles of the European Pillar of Social Rights, and that's the European semester, and to that one, the Recovery and Resilience Facility and the National Recovery and Resilience Plans are linked. And just very, very quickly, the European semester, for those of you who are not familiar with that, is an EU-level mechanism of socio-economic coordination that steers investment and reforms at the national level, issues analysis and country-specific recommendations for member states, how to do these reforms, where actions are needed, and annually tracks the progress done. But really what's important is that there is a big potential for improving social and economic upward convergence, just transition towards green society and inclusive growth. As I said, it's now linked with the European Pillar of Social Rights, a set of 20 principles that all EU member states committed to fulfill or achieve by 2030, hopefully longer than that. And access to healthcare, to preventive, timely, affordable, and close to the people healthcare is one of these. But as you can see, hopefully, there are many more which we considered really investing in health equity, social protection, childcare, work-life balance, wages, minimum income, inclusion of people with disabilities, long-term care, and so on and so forth. So steering investment and allocating EU funding. Since 2011, 2012, we've been analyzing the country-specific recommendations issued by the European Commission to the member states, looking into what's the potential of these recommendations to improve public health and health equity. And last year, for example, we looked specifically into the resilience plans in the EU member states, and we looked into 8 EU member states. Poland wasn't one of these, but we looked into Spain, Latvia, Belgium, Austria, France, Sweden, Italy, and Finland to see what's the potential of it to reduce health inequalities, improve health equity and well-being across the social rights, I'd say, dimension. I have 3 countries examples, just very quickly. For example, Belgium, really very much focused on prevention, health promotion, and digital health solutions. And we are talking here about a lot of money, really, to be invested in the next 4 to 5 years. Austria, really big focus among the funds allocated for healthcare systems to community care and life course, focus on children, on community nursing, on expanding early childhood network. And Italy, big focus on health, environment, and equity, specifically in improving sustainability for the environment and citizens' health in Italian port cities, and also looking into health and equity co-benefits to support climate change response plans. It's a regional plan, this one. Now, I don't know how much you're familiar with, or probably you know more than I do, actually, but I took a look at the Polish Krajowy Plan Odbudowy, the Polish National Resilience or Recovery Plan, and I found that 4.1 billion euros is to be invested in health out of a bit more than 58 billion. Yes, okay. So, okay, I'll just leave it. I presume the presentations will be shared with you. So just very, very quickly, I wanted to focus on this project, which is a new one, just for the next 2 minutes, literally. We've got involved in a project called Invest for Health. It's a four-year project funded by Horizon Europe, which is really going to look into mobilizing novel finance models that work for health promotion and disease prevention. And it aims to help organizations in local health and care ecosystems to reach their full potential, to build and maintain healthier communities, so much wider than individuals or households, or even going beyond the health systems as we know it. And it will develop and test models and alternative governance mechanisms together with decision and policymakers and citizens panels. So I think this is important, this co-designing and participatory and close to the people element, to facilitate the use of something that we want to work out, something called smart capacitating investments in health promoting and prevention. And just out of these, it will be implemented and evaluated in 4 regions in Europe, in Spain, Germany, Sweden, and UK, well, Wales. So the regions are already chosen, but what's important, I think, and interesting is that there will be a launch, we will launch also an open call to attract a second group of regions to test and provide feedback. So if anybody's interested, would like to know more, I very much encourage you to get in touch with me. I will show, I can share my contact details. So just to conclude, do something, do more, do better. So to recognize the value and invest sustainably in health promoting and social care enabling initiatives as part of broader health resilience and reform strategies. The element of communication, more transparent communication between the sectors, between the stakeholders, is important about how the funds can be designed, can be spent and accessed. I think this is something important as well. We think there's a need to develop an overarching strategy for the EU and the member states, or for the EU to guide the member states to integrate the goals of the relevant strategies, and also going towards working across the sectors. Perhaps I just skip to the last one, and guarantee resources, capacities, and inclusive mechanisms that will encourage public health professionals, and health policymakers to engage with the EU processes and other sectors, because that's important, not to just do something within one sector, something that's one-off, focused on fixing the damage, but looking forward. Thank you so much. Yes, that's it. Thank you.
Thank you very much for sharing with us European or Brussels on EuroHealthNet perspective. This is very interesting, and you gave us many inspiring data in the field. I'd like to admit that I'm really shocked by the percentage of children in EU living in poverty, as this is something not even surprising, but quite shocking for me at least. So thank you very much for that. And now I'd like to ask Ms. Elia Diaz, and I hope you will present us your angle from very down-to-earth and acting and experienced work in Barcelona. The floor is yours. Thank you.
How I pass. Thank you for having the opportunity of being here. Yes, I'm from Barcelona, from the Public Health Agency, and my presentation is to put in some way to operationalize what my precedent speaker told. It's just to put the view on health from a local municipality as Barcelona, and a Mediterranean quite big city, and see how we are and how we feel the road to health should be. Then the title is Barcelona Key Ideas to Understand the Road to Recovery and Health. Well, how we are. The graphic shows, well, in Barcelona we are living about 1,600,000 people, and we have been in more or less the same number of inhabitants, and we lost population with the pandemic. These are the differences. The ordinates axis It begins at 600,000. And then we increased our population from 15 to 19, but then we decreased, of course, and we are slightly recovering, but we are more or less the same. Okay? But, and what about economy? Well, let me tell you that our data, these data are from the public health view. And we do every year a report who our political representative presents to all the municipality. And it has, including in the last decades, social determinants, economic and social determinants. And one of the questions is, for example, in the last health survey, difficulty making ends meet. Making ends meet. Its meaning. The meaning is, do you reach to achieve with your budget all your needs by the end of the month? And then here you will find in all our graphics by women on the left, men on right, because there is a gap and we want to look at it, that, and this is much difficulty in red, medium difficulty or some difficulty, and and the rest have not difficulties. And what we see is, and this is by social classes, from the most affluent on the left, less affluent on the right. And we see that, a big, 6 out of 10 people in disadvantaged social class have problems to make ends meet. Yeah? Okay. So some of the responses, one of them in Barcelona, there are municipal offices for advice on how to avoid water, gas, or electricity supply cuts, for example. Or a dentist. Much of the healthcare problems are due because we have an universal coverage in Spain and quite a good primary health care, although with problems in the pandemic, but dental care is out of these provisions. So in Barcelona, they prepared, and then there are 3,000 people who have already had these services, a dentist for people in vulnerable situations. This is not a vision. This is the way to, a vanguardist way to respond to problems. And then, okay, one of our main problems are those depending on pollution levels. Here, the graphic on the left is the evolution of the annual average of nitrogen dioxide and small particulate matters on the right. And then the red line, well, and this begins on 2010 and ends in 2021. And you see that we have been above the recommended lines of WHO or European limits forever. Right now, well, with the pandemic, of course, it was reduced, but we are still above this in both indicators. So this may interest to you in this economy congress is that we have about 1,200 deaths annually calculated, the mortality attributable to air pollution, 750 new cases of asthma, or 100 cases of lung cancer, and the cost of these cases is about 3 million euros and 2 million euros respectively. Pollution levels before the pandemic were worse, of course. So what happens with school? The children at schools are exposed also to pollution. And then this is the distribution of pollution of schools exposed to different levels of pollution by districts. In Barcelona, there are 10 districts. And you see that in some of them, in red, they have more micrograms per cubic meter than the other. Some of them are in green, and mainly, and some of them are in orange and red. And this is on the left here. These districts are the most in the inner city. so children are exposed, 4% of the schools and of the children. Okay, so this is an example of how community or citizens may they may prepare responses when they are worried. And this is a new way of going to school whose name is bike bus. Some families in one district, one of the most affluent, on the other hand, and not the worst in terms of pollution, began to take the initiative of every Friday to cut the streets and go by bicycle with their families, cutting everything. The newspapers were aware. Now this is a kind of solution, and this has been pushed by the municipality. This is cheap, well, in some terms, no? And then it was very interesting. And now, I don't know. Okay, then now there are many schools, some schools, not so many, but quite a number of schools doing this. I don't know where okay. Another way of reducing the pollution to whom children are exposed. There are safe routes to schools. What we have done is to evaluate the traffic injuries, making this kind of ways to go by pedestrianized in some way to school. The traffic injuries were significantly reduced in the intervention in schools, especially among children. And then this has been recently published, and we are quite proud of it. Or, for example, another way of acting against this is showing to the citizenship how, well, talking about heat waves, which are very dangerous in our country, showing that the probability of an excess of mortality risk by a 1% increase of high temperatures in summer is not homogeneously distributed, but there are neighborhoods who are more exposed and more at risk. And then what has been done is a model of climate change mitigation and adaptation policies in Barcelona. On the right here are the outcomes, direct impacts of climate change in health and health inequalities. We work always with this model of health inequalities. And then consequences of climate and on climate in environmental, in social, and direct effects. And then on the left, who are those who determine this consequence? The power structures, the governments, the social and economic stakeholders, the values and culture of the society, and this acts through power access of inequality. Okay, so what? Oh, okay, so I'm finishing. So we have done climate shelters at schools, climate shelters at parks, try to make a city more greenery, places to walk, to bike. Look at this road. There is a bike line, a bus line, and a small place for cars, libraries. We are changing the city. The idea is this model of super blocks means that we want to change the mobility in favor of the cars to mobility in favor of other not motorized vehicles or simply walking or biking. And then, this may interest to you, we did a health impact assessment which resulted in an average increase in life expectancy for 200 days annually and an economic impact of 1.7 million. And this has been published. This is two ways of addressing these changes in a compact and very dense city as Barcelona, by areas or by access, green access. These streets and one of them, which are in the, not in the center, strictly center of the city, but in the 19th century city. Well, the changes are like this, you know, from a road to a place where people, children play, may stay. This has been done in several places. Well, this is about COVID vaccination. Just to tell you that in Spain we don't have any kind of problem of vaccine hesitancy yet. We had a very high percentage of vaccination coverage, although, as always, the distribution is uneven. Well, we are just recovering the underdiagnosis of chronic diseases. Yeah. The daily tobacco consumption is still high. It's about 20% from 16 to 19, 20%. And we should decrease this because it's completely related to chronic diseases and to mortality by cancer. What we have done during the pandemic and after the pandemic, and we are quite proud of it, is that even lacking a new tobacco law, which we are expecting, we made an aqueous experiment and measured, putting an intervention group of beaches in Barcelona and a comparison group of beaches and doing almost 10,000 observations. And we found a very good impact in this in 2021, a reduction of 70% of people smoking, and everybody very satisfied. 8 out of 10 citizens were satisfied with the initiative. And then in 2022, this was extended to all the beaches. Well, we have worsened mental health in adolescent and adult people. We see that this depends not only with housing. This lady got a house, which is very difficult in our city because we don't have a proper policy of housing. It's very dense and it's not easy. But also we work against loneliness. There is a project in the most deprived neighborhoods who try to enhance community life against loneliness. This is another way of increasing conviviality without doing anything more than cutting streets once a week. And this is quite successful. These tactical measures were put in practice during COVID. Just to probe, we followed the example of New York. They told us, don't panic, do tactical measures and wait and see. You may have reactions, but you are not just putting any kind of money.
Ali, I'm extremely sorry to interrupt, but I'm afraid you have time just to conclude.
Yeah. So.
Thank you.
Yeah. Okay. The conclusions are, to me, those that the way we think of health is determinant, and from health services we should move to prevention and health promotion, and in the cities we are able to do many things. We should provide evidence to provide evidence about trends, inequalities, think of the people who are not in the surveys, model the possible future situations, lobby with the other sectors, for example, in our case, mobility, urban planning, beaches, promote social cohesion, empower community to take action, and evaluate everything and make the evaluations accessible. So thank you, and excuse me for my long presentation.
Thank you very much. Actually, you gave us a big number of examples and a bunch of activities we could implement even in Warsaw. We could consider opening a smoke-free beach on one of the banks of our river. So I love your ideas, especially riding a bike to school, although I wonder how many of the used bikes are electric bikes these days. But anyway, thank you very much. And now there is a time I'd like to ask Gerardo De Cosio to present WHO perspective. The floor is yours. Thank you.
Thank you very much for the invitation. I'm going to try to be a little concrete because I really acknowledge the two previous presentations who my work is going to be somehow summarizing what has been said. So it's going to be a lot easier for me to do it this way. But I'm going to speak from the perspective of WHO, which is the organization I used to work for, and I'm going to be presenting on behalf of Paloma Cucci, who is the country office representative. I'm not living or working in Poland, but I was visiting Poland, so I thank her for giving me the opportunity to present in this forum. Well, my presentation is going to be focused basically on health services, workforce. I'm going to put a lot of emphasis on the workforce. Thirdly, mental health issues, which is a very important issue that not it's only an issue of the population, but also an issue of the workforce. And finally, I'm going to close with some of the results of the household survey that WHO, along with the Statistical Commission of Poland, conducted in terms of refugees, how this is also impacting the health services, not just only of Poland, but of many other countries in the world. So basically, that's going to be, where is, this is the one? And not just press the green one? Okay, thank you. So basically, the pandemic really created a lot of problems. We have to reorient our budgets and our human resources in order to respond to a pandemic. It was a crisis. It was very catastrophic, the response that we have globally. I'm not talking about any country in specifically. So WHO has proposed another plan which is focused in 3 areas. One is going from crisis to recovery and transformation. But to go to transformation and recovery, we have to rethink the way we do things. And as it was said before, we have to have services that are patient-centered, not the other way around. And also the focus has to be on primary health care. And also we have to include or integrate the concept of health security into the whole concept of health systems. Also, we need to go to the all hazards approach risk management, which also has to keep into consideration other concepts that WHO has been promoting. And I guess that many countries in the world are beginning to adopt the concept of one health approach, which includes not only health, but you have to include other sectors as well in order to address health issues as well. Then the concept, as it was previously said, the concept of whole of government and whole of society approach is no longer acceptable to keep working only on the health concept without taking into consideration other sectors as well. And in order to do the whole thing, we also have to keep in mind the concept of life course approach. And this takes into consideration some previous comments about why we only talk about aging and not children as well. So the life approach has to go from the beginning to the end of life. Then the pandemic, the COVID pandemic also brought another problem, the workforce worldwide. We discovered that our systems were fragile and were not prepared to respond to a pandemic or a health crisis like this one. So we need to work with the health approach. In Europe, we know that about 9 out of 10 nurses have declared intention to quit their jobs. I mean, we have put tremendous pressure on the health personnel that sometimes they cannot cope with the daily work that they have to be conducted. We overwork them. They are overloaded in many ways. So that's why it's important to keep them. And also keep in mind that this goes to the other part of my presentation is mental health among the health workers. The region has saw a staggering 62% increase in workers' absentees. Absenteeism has been tremendous all over the world. And I didn't include one more thing, but it's important. Workforce migration. Where health personnel is migrating for many reasons. One could be because they are looking for better opportunities. Another one, it could be because other countries are stealing the workforce of the other country, which is also a true fact. In some countries, over 80% of nurses have reported some form of pandemic-related psychological distress. And most probably, if you were working during the pandemic, whether you were a health worker or not, most probably you were under stress. Even if you were at home waiting to see what happens with the pandemic, it was a tremendous stress, a lot of violence, a lot of abuse, a lot of, just name it, and everything happens at the same time. Europe has seen mounting numbers of strikes among health workers. You can see what is happening in France, in England, in the United States, in everywhere. And I'm not going to mention Poland because most probably they are suffering the same problems that other countries are suffering. Then health workforce is a good investment, but we hardly recognize. We don't work sometimes with universities in terms of developing, promoting the creation of health workers at the workforce, because sometimes we limited our resources and we don't work with them to create more health professionals, and not just create or develop health professionals, but also give them some incentives to stay into the job as well. So that's important. Then the return on investment on health has been estimated for every $1 that we invest in the workforce, we may get $9 back into the labor, into the economy of that country. So that's extremely important. And life expectancy increases with the GDP if we have a good workforce as well, regardless that life expectancy has been decreased lately with the COVID pandemic, perhaps with the war and whatever you just mentioned and everything that might be true. So in response to these challenges, recently there was a Bucharest Declaration, which is mainly a political action, but regardless it's political, I guess that we take into consideration this will move forward. So we need to improve the recruitment and retention of health workers. We need to improve health work supplies mechanisms all over the world in order to ensure that they have the supplies that are required. We need to optimize the performance of the health and health workforce everywhere in the world. We need to plan from the beginning they go to the university to the end before they retire. So we plan that we have enough people that is replacing them. Just keep in mind what is happening in Poland. We have an aging health workforce. So we need to plan to see if Poland is going to suffer what the other countries are already suffering right now. And we need to increase public investment in workforce education, development, and protection. It's not enough just to go to the university, but we have to keep training and retraining. Someone mentioned before me digital health. How many health workers are literate in digital health? Perhaps not that many. And then the health survey of the refugees, the household survey that WHO, along with other institutions in Poland, conducted, are giving us some numbers of just think, in a matter of weeks, the population of Poland went from increased by about 6 to 10% in just a matter of weeks. And all this population was also demanding health services as well. So that was an important, and I was putting a lot of a burden into the health system in the country, a system that was already stressed because of whatever was happening right now. So you have on the right, on the left side, I mean, the most common problems that were requesting the refugees when they came to Poland. But those were the initial programs that are normal, so they perhaps were the less expensive problems. But see the other problems that they were bringing into Poland, which are perhaps the most expensive one to deal with in terms of treatment, because they require a lot of care in many ways. Then healthcare out of pocket. As you know, most countries in the world has that problem. You pay a lot out of your pocket to cover your health expenditure. And sometimes you don't realize how much of that money is. That's why we need to increase our health expenditure in the country. I'm going to finish. I think I need 2 more slides. So that's important. And then I'm just going to say, investing in treatment is going to create a lot of benefits into the economy of the country. Increases by 1 trillion each year the cost of depression and anxiety. That's mental health if we don't deal with mental health issues. Mental health also has a return for every dollar invested is scaling up treatment for depression and anxiety. So it has a return of $4 in better health and ability to work. And we have to pay quite a lot of attention into the mental health problems of our communities and our health professionals. Otherwise, the way that we treat people may not be the best way to do it. So you can see it's extremely important to increase that part. And then finally, some of the reflections that were addressed from the household survey are we need to pay attention to healthcare, to modify or develop existing health programs, services, infrastructure, consider language as a barrier. Information is extremely important to be given in an easy and simple way. So we need to start talking about health literacy. It's not just about giving the information, but how do we understand? And this is not only for the refugees, it's for everyone in the world. So that's an important time. And others that you can read, but the most important one is the mental health issues. Mental health is not only among refugees, but it's also among the health personnel that is taking care of these people, not just the people that is coming from abroad right now, but also from the local population that requires a proper treatment, and especially among the aging people, which are very important, and of course, adolescents and children, just to cover your concern. There are the children with disabilities, important, increased vulnerabilities among the people, and I would like to emphasize many of these people has problems, HIV and tuberculosis, and there is a lot of stigma among this population. So we need to take care of that kind of issues. Coordination of civil society and international standards to be taken into consideration when we provide care for them. And this is, I'm not going to read any of these things, but this is the concept that in order to address all of this, we need to work under the concept of whole of government. It's an integration of all the sectors working together to improve health. And finally, if we have good health services, we might get to universal health coverage. If we have health and income and social security, we may have to consider unemployment insurance. Remember that a lot of the population is working under the informal sector. And that sector, most probably in many countries, don't have access to healthcare. And finally, I'm not going to go through all of them. You can read and more or less agree, hopefully, and not disagree with me. But health and living conditions are extremely important. We have to work on the environment, all of these people, in order to improve the health situation, because as it was said before, the environment is also creating other health issues that most probably we're not taking into consideration in many ways. So thank you for your attention.
Thank you very much for sharing with us WHO perspective, and especially for showing us numbers which show huge impact on health investments, on economy and growth. So thank you very much, and I am especially grateful for fitting in time frames, as this secures my mental health as responsible for timing. So thank you very much. That's all for now, at least during this panel. So thank you very much for your presence and attention. And that's all. Dziękuję bardzo.
O, chyba mikrofony nie działają.
Let's start a very practical part of the Congress. In the first part, we spoke about a scientific approach. Then we saw how particular local governments are approaching the solution parts. And the next session will focus on initiatives that are undertaken by the municipalities to improve the health of the citizens. The experts will tell us about the activities undertaken in Poland and abroad to improve the quality of life of the inhabitants. Professor Jacek Sierak from the Warsaw School of Economics, and he will be the moderator of this session. Let me invite the panel members. Konrad Fiołek from Rzeszów, Jacek Karnowski, president of the city of Sopot, Renata Kaznowska, deputy president of the capital city of Warsaw, and Hanna Zdanowska, president of the city of Łódź.
Tak, rzeczywiście chcielibyśmy, żeby
We would like our panel discussion to be practical. We all want to live in healthy cities. It's a dream of ours. We all want to benefit from certain public services at a high level. That includes health services. But the way we understand healthy cities is a wider perspective. It includes environment, infrastructure, the space, demographic changes. I'd like to discuss all of those aspects in this panel discussion with distinguished guests. Local governments are very diversified in Poland. It would be difficult to compare a big agglomeration with a small commune. So we have representatives of Warsaw, Łódź, Rzeszów, Sopot. These cities differ among themselves as well. Different social economic specificities, individual specific problems and challenges. But there are many things in common. There are challenges that we share. The needs are so bigger than the capabilities of satisfying them. So with these great guests, we're going to debate about how we can meet those needs. Is the funding enough? Are the tasks divided in an appropriate manner? Let's remember, for some years already, our cities have been operating in very difficult conditions, in an unstable environment, and the environment is stable in social, economic, and health-related terms. So we prepared the index of healthy cities here at the Warsaw School of Economics. I'd like Professor Agnieszka Chłoń-Dominczak to briefly present the results of our project. The floor is yours, Professor. Let me add, we have the cities here represented who are well located in our scoring index. Well, the Index of Healthy Cities is an initiative of our school and of Open Eyes Economy Summit and LuxMed. So we had a broad overview in a very diversified perspective on what's the situation in the cities in terms of health, public services, education, transport. All of those determine the quality of life. So we created a sort of ranking where Warsaw is the top of the stake. In Sopot, however, we have the best natural environment. So we didn't have Mr. Mayor with us at the beginning, but we know that many people from Sopot spoke about how important it is to include environment as a determining factor. So we use all those indices, factors, and data from the main statistical office, data from the Agency for Health Technology Assessment and Verification, data from the Central Exam Commission that deals with schools tests, because we included the well-being of school pupils and students. So our perspective included diversified aspects. On our website of the Congress, we have the publication that you can download to learn more. Let me finish by saying this, because we have representatives of the cities, and it's very valuable to hear from you, ladies and gentlemen. Thank you.
Ladies and gentlemen, I'd like to have a discussion first. So let's maybe start with 2 rounds of questions. I think it's a dream of every mayor to have a contact with the room. If we still have time, we might devote the last 10 or 15 minutes to questions and answers from the room. Our cities are diverse. We're in Warsaw. Warsaw is also on the first in the ranking. So why don't we start with Madam Mayor? Warsaw is the leader, the first one on the index, but it was not necessarily the best in the individual areas. Can you say that, well, we know that Warsaw faces so many problems. Do you favor sustainable growth, or maybe it's difficult for a city with such a large population and such a broad functional area to be ranked first in any of those areas? I'd like us to allude to our index. Is it inviting to an in-depth analysis of needs, and I mean both in qualitative and quantitative terms? Does it make a difference? I mean, this index, is it helpful? Thank you very much, and a heartfelt thank you for the invitation to this debate. I also thank you for the index, and starting from the end, it's very important because it's very measurable, and I hope that it will be continued in the years to come. Like my colleague has said, Warsaw not necessarily ranking first in the index of well, ranking first on the ranking was not necessarily best in any of the areas. Sopot was first. It was number one, I think, in the environment. Mr. Fiołek was ranked first in, I think, services. Warsaw was number one in one of the areas, but it ranked very high in all the others. How does it come? First of all, the municipality council adopted the strategy Warsaw 2030, and there we defined the strategic goals and then individual tactical targets. Owing to this, there is no area that would not be taken care of. We pursue the policies, and we were ranked second in health, education, 3, housing number 5, and so on. And all in all, this translated into the first ranking in the whole index. And that's why I wanted to congratulate you on the index, because we know what we have to improve, that we have a lot to do. So definitely we will be continuing our challenges in many areas, both in environmental protection. There's still a lot to do, even though we're pursuing multiple policies connected with renewable energies, planting. We are pursuing the Adapt City resolution, the adaptation of the city to special challenges and the changing climate. There are numerous such areas, and we are very consistently pursuing the individual policies, like the exchange of the old type furnaces that we had. 15,000, 10,000 have been replaced already, and we're doing a lot. There's still probably a lot to do. I'm sure we'll be discussing it further through the discussion. Madam Mayor, can you even identify needs in such a large city? I mean, the city is very diverse when it comes to the districts. Not only can you, but you should actually, and we're doing so by using numerous tools. One of them, very valuable for us, is the Warsaw Barometer. That's a survey we perform on a large sample, a survey where we ask residents in each of those areas. It's a very lengthy survey and very important for us. Right now we're preparing for the next issue of the Warsaw Barometers, and the results of it are a very significant determinant of our work for the next years to come. That's the beautiful word, participation. Exactly. So we have the citizen budget, participatory budget. It's also a great way of achieving participation. If I may, Madam Mayor of Łódź. Łódź is a city with traditions, quite specific, shall I say, in its culture, in terms of its culture. We've heard a lot about rehabilitation of Łódź, and it probably affects all the Łódź residents. The comprehensive rehabilitation of many areas certainly requires cooperation of numerous entities and often contradictory groups of stakeholders. How are you coping with this? I'm sure you are one of the leaders of space revitalization, and your rehabilitation policy has been quite active since when you started to restore this unique status of the city. Does that enhance the health of the city? To what extent and how? If we could just start with it. Because whenever I visit Łódź, I can see those changes. First of all, I'd like to thank you for the invitation. Good afternoon. It's rather a rhetoric question. Yes, we rehabilitate the city not to create a museum. We rehabilitate it for people to reside there, to live there with access to all sorts of energy, utilities, water, sewage, so that in their buildings, townhouses, they could live by today's standards, because which has become a forsaken scanson of sorts. This is connected with infrastructure, but also all the things that translate into social life of that part of residents who live in municipal buildings, community housing, because those people, owing to the neglect, remained in the 19th century. And it's actually about taking care of the quality of life of those people. And we need to, therefore, change the environment, their living conditions. That's about also health. If, well, my mayor mentioned 15,000 stoves. When I started my office, we had 80,000 old type stoves, and right now we have about 20,000 that we are first of all doing away with those furnaces or stoves, giving access to other alternative energy sources, renewable if possible. Owing to the rehabilitation process, we've been able to lead district heating to the central district, to downtown Łódź, because it didn't exist. And owing to this, we're starting to live in a different world. This directly translates into health, because we're talking about pollution, about particles, solid particles. On the other hand, we are also being impacted by the aging society, and those people left to their own devices, older people, because young people either emigrated when there were no prospects of a better living in our town, or they have increased their standard of living, and they bought their houses or apartments in better, so to say, districts with a better urban space where you can spend your time. That's why rehabilitation was key to the leveling of the living standards among all the citizens, the restoration of downtown life, which indeed had faded away a bit, because at one moment in the 730,000 strong city, in one of the central districts, the population only amounted to 20,000. So you could see the outflow, the aging of the society, and the people who stayed in the old residential areas was a problem. And right now it's being revived, because indeed you can see the need and the willingness, and most importantly, the joy of those people who did not even expect a better tomorrow, that they can again stop being ashamed of their living conditions, and that they can safely think about the future. And this also translates into our living standards, i.e. also health. You are creating programs to this end. There have been and will be there. You cooperate with many stakeholders. I'd like to ask, which entities are helping you in your work? First of all, we've involved and created certain synergies between or among all the acting stakeholders. One of them was the new strategy that we've implemented. This is the co-created city. So first of all, we involved the residents themselves. The allocation of over 10,000 residents to perform anything is not an easy task. We know how difficult it is to persuade people to move someplace, even on a temporary basis, even if we realize that this will substantially increase our standard of living. Well, you can believe me that it actually created, it was performed without any problems, seamlessly. We involved the torch holders, that's what we called them, who were to persuade people to move on a temporary basis, and who then taught them about the functioning in the city. This involved problems not only connected with housing, but also social problems, because that picture of a rundown city triggered many social problems. So we invited the residents, the NGOs, business that is supporting us by creating new spaces, and business social responsibility, corporate business responsibility, and also connected with greening, the adaptation for climate changes, because EcoPact has become the source of new energy or carrier of new energy, teaching us how to create a balanced and a sustainable city. So together towards success, yes, absolutely. And here you can see that identity and common care about for the future. That's what we built together, because the greatest problem, one of the greatest problem we faced, was the reluctance to identify with the city. Now the pride and identification has been revised. Now, if I may, we will pass on to the problems of Rzeszów. In our ranking, Rzeszów is first in two areas: population, social services. Rzeszów is the first among, in many terms, as a top place to live. People can afford to buy an apartment. There is a place in the kindergarten for each child. That's all true. Rzeszów is also a city with a large demographic dynamic. People, that's the town of young people with a positive migration balance, so quite reverse trends than those where you can find in other places. This is probably also the aftermath of an aptly applied urban policy. The care for social services, I think it attracts people and lets you and allows you to manage the services. How do you perceive it? How come you achieve such good results? Well, after what the professor says, all I have to do is to invite you to Rzeszów, to move to Rzeszów. It makes sense to live in Rzeszów, and the quality of life, objectively speaking, is very high. Let me just tell you why, but owing to my presence in such a distinguished university with so many distinguished professors, let me just be controversial first. I think that not so long ago, the quality of living in our town, actually in our towns and cities, was measured by the quality of asphalt in our the quality of roads, the comfort of drivers moving, forgetting that, well, that would be best to get off their bed and drive to the very desk in the office, and that's what we try to take care of, without care for other areas, because it was most important to allow comfort for drivers and to pack them up near the place where they live or they work. And another traffic lane was more important than green areas, and probably only the availability, the awareness of the global climate crisis, and then the COVID. Only then did we start thinking that maybe the Volkswagen is not most important when it comes to the quality of life, but also other areas, and that translated into a great opportunity for such towns as Rzeszów, which is quite large. It can provide public services as required in a city, and owing to its smaller size, it can take care of the quality On the other hand, it has fewer downsides to living in a large city. It also had some disadvantages, like you are not a large agglomeration. You have to find your own idea of ensuring first education and then work, which was also easier owing to the aviation traditions, the aviation valley, and also owing to the demographics and the slightly, traditional factor that you don't have all that much impact on. The demographics were helpful. The offer of the town helped attract young people, and they did. They did arrive, and we tried to smartly manage those needs. Now that where we won out in one of the category, i.e. demographics, life expectancy, or youth, more objective ones that characterize both Rzeszów, but shall I say also the southeastern part of Poland, though we were characterized by those demographic factors, and it was objectively easier to be ranked first. But when it comes to social services, that's always about taking care of the preschool, nursery school index, access to sports infrastructure, or even district heating, municipal services. That's what we were able to achieve. We were smaller, and it was probably easier to take care of that. I'm sure that today, what we're facing are huge challenges. And after ensuring that quality of life to the driver, it's time to ensure the quality of life to the man in the street. So, as you mentioned, what we're doing, I think we'll have plenty of opportunities to discuss it in the latter part, but I agree with Madam's mayors that consistency is the key to success. I'm a new mayor. Yes, time sure flies, but the consequences of it, like I've been watching our fellow local government activists, consistency goes a long way because the resident would like to have quick wins. But only consistency yields the quality of living at the end of the process. Indeed, you mentioned the fact that you have been in office for a relatively short period of time, but you've been a local government activist for a longer time. To what extent do you use each other's experiences from Łódź, Warsaw, Lublin? Do you meet? I understand that you're friends often. Well, I can share some stories from Rzeszów because during my local governmental campaign, I invited the other mayors or people running for mayor, and this makes a huge impression on the residents. Like Ma'am Ma'am Mayor of Warsaw and Ma'am Mayor Zdanowska also showed how to manage the process of green installations, and it was also headed by the mayor of Sopot. But it made an impression on the residents that we're going in the right direction because that's the direction the whole of Poland is heading in. So that exchange of experiences could be seen in the streets of our town. And I think that it was then that we were all persuaded what a great reservoir of the know-how we provide as local government activists. It's a different thing whether someone is listening to us or willing to fund it, but I think we can do it. So it's like a family, right?
Mr. Mayor, Sopot is a city of good natural environment, city that supports physical activity. And I've been looking through the documents, I see that you're very consistent in preparing good programs and implementing them, and they refer to the environment, the municipal heating plan, the gas projects. They started back in 2011, then consistently you have had coherent, consistent policy for natural environment. So could we address the policy for a smaller town, tourism and health, and then youth and the municipality? So could we address those briefly? Thank you very much for the invitation and giving me the opportunity of being here in this beautiful academic environment and this beautiful hall. It really impacts my health very well. Well, we have this specificity, you know. When we go to a city, we look at all those factors here. We used to visit cities in the US or Sweden to see what we can see here now. We all went to some cities in Ukraine. I've been to Odessa, and you know what? We can learn from them as well. We could learn, for instance, how civil security or some defense elements are organized there. I feel well being in Warsaw or in Łódź, wherever I go in those places, or in Rzeszów, by the river, there are trees, there's green factor there. I'm proud to see Poland increasingly green. That's very important. In the 90s, we saw a breakthrough. At that time, Poland was poor in local governments, but we had a fund for the natural protection, and it worked. And we could take loans that they were redeemed. Redeemable loan, it's what we give, you know, to kids, or grandpas give to children. So if you performed the task, the loan was redeemed. Well, the result needed to be obtained. So there was this slogan in the 80s, you want to have skin problems, enter the water. We had to face the water pollution problems, and we did it. When we have bad day of air pollution, that's a catastrophe for us, a single day. But there are cities where we go out into street, we can feel the pollution. What now in Sopot we don't feel that anymore, but in some places you leave home, you go to the street, and you can feel the pollution there. So now the green parts, that wherever you start, from whatever point you go, in 15 minutes time you can reach a green zone. Now another part, young people in Madam Mayor is preparing a great climate conference on the 18th through 19th of May. I'm giving you some good publicity. So we gave young people at the Council of Youth some money, so they have their budget. It is an agreement between the Municipal Council of Adults, they are responsible for the budget, and they received several thousands of zloty. What did they spend it on? To improve mental health of their peers. We were ashamed, and we've spent dozens of Polish zloty. But can you see how responsible these people are? Participatory budget is the next point. At the beginning, I was not in favor. Which mayor enjoys giving out his or her competencies? But I got convinced. So we have this budget. And again, adults, they vote, and it's 17% of adults and of the inhabitants, 17% out of the whole population. And Magda Czarzyńska, my deputy mayor, when we gave the young people their own participatory budget, the attendance was 67%. So we cannot really complain about the attitude of young people. They get mobilized. So it's really worth investing in them, because it's them who know what's best for them. You know what the rate of suicides in young people is. It's staggering. The problem of mental health in young people. You know, it's worth giving them decision making. They don't need to ask only, but they are able to make decisions. They started networking, you know. Soon they will replace us. So they connected in networks. So what we need to do is to give them budget to enable their meetings. So again, it's up to or down to good contact with people who live in the cities. Young people have their problems. Senior people have their problems. I remember my first visit in Łódź with Hanna Zdanowska. I was on my way to the mountainside and I was crossing Łódź. I wanted to have a meeting and talk about the municipal housing or flats for students. And Madam Mayor told me we have 5 minutes to take a coffee and then we're out and we're going to have a tour of the city. And with Konrad, with Marta, it's the same. We prefer to walk around. It's very good to say good morning to everybody, and we recognize how many of those people say good morning back to us. You don't need to spend thousands of złotych for a public opinion poll. You just say good morning and you immediately see whether your activity is perceived well or not. For me, it's easy to go around Sopot. I will take 3 tours around Sopot, but in Warsaw, in Rzeszów, in Łódź, the principle works in the same way. Just have contact with people who live in your city. Thank you very much. Let's go back to Warsaw. 395 health-related programs in various areas. How is that even possible? It's a huge number. Some people say it's not possible, so how are you able to do that? Well, it's not an easy task, but we're doing our best, and we're very happy to do that. These are very important programs. Every year, we're considering what should we do next, because we have little time. I want to address money. So if I may, let me make reference to mental health as well, as Mayor Jacek has just mentioned. We won a competition in the best vaccination rate in the commune. And you know, majority of the funding went for the mental health support for children and youth. We all see that after pandemic, when we saw the pandemic ended and we're going back to the so-called normal, the 24th of February last year came and the war in Ukraine started. All the polls that we ran showed that we really need to take care of the mental health, not only of children and youth, but adults as well. And this is where we really need to focus on. Not only that, the health debt after pandemic is unimaginable. Our expectations are consistent attitude of requiring the funding from the Ministry of Health and then redistributing them in a smart manner. We keep hearing that millions and billions of złoty are reallocated for health protection, but I have really serious doubts about redistribution of the funds. In Warsaw, we're a great example of a certain phenomenon. We have very many hospitals that are so-called the community hospitals. We have 11 hospitals in 9 so-called companies, huge projects, and over 100 ambulatory outpatient clinics. So let's go back to your question. How can we perform so many programs? This is a huge effort, financial included. Let's take an example of last year. The worst is that we're on a downward trend in health protection, and it's spiraling down. Last year, the overall loss was 98 million Polish zloty in all the hospitals combined. When we collide that information with the second financial information, that under the tax changes, under the so-called Polish deal, Warsaw has been losing 7.5 billion zloty. We receive a compensation of 900,000 zloty, and the rest of it is gone. So to find money in the budget after the pandemic, in the war crisis, when we are trying to help the refugees here, we have 17,000 students and pupils from Ukraine. It's like 1 year more of a headcount of a regular number. It shows the huge scale of challenges. The same is in healthcare. 89 million Polish zloty of loss from the last year only. And every domain of life looks in that matter. The local government will lose income. We required the share of the local share of the income tax, and we have been asking for that for a long time, and it hasn't been responded. So once we speak about improvement of quality of life, we said how much we do in terms of strategies. These are like our small constitutions, but without the funding for it, it's impossible. Our inhabitants can see how the communes and the city is evolving, and they appreciate it. It's really not possible to carry on without the funding. Environmental protection, removal of the old stoves, all of that need to involve our own funding and EU funding. So we really need the new funds. Without that, we are not able to implement our projects. We have already moved some of the projects. We want the third line of the metro and the fourth one, and we've been working on that ideas. The tram lines, not only a better and more efficient transportation within the city, but more green ones as well. We need funding for all of that, and that includes EU funding. What you mentioned was very important. The financial stability and efficiency of the particular sources of financing. So when we build the strategic programs for the development, they should be based on foundations such as own income of the local governments, stable, repeatable, and on that we can build the programs for long years to come. With subsidies, we never know whether we receive them or not. So how can I assume for the next 4 or 5 years that I'll be able to prepare the program and implement it? We do not want to let our people down. So addressing wood, you used to have challenges related to the emissions. So you introduced the programs for low emissions, And what we've heard before, you received a lot of EU funding. So when you did not have benefits from the tax policies, actually you lost some income from that. So are you not worried that you will face a problem, that you're not able to have your own funding for the EU projects that need co-funding? Large cities benefited from those fundings a lot. So will you be able to use the EU money in the long term? It's a question with an answer. No, we won't be able to do that. What would you need then? To use the money, the new program, it is limited in time. And what? We want to use this National Recovery Program money. If we are not included in any programs under the partnership agreements, and we received 1/10 of what was possible in the previous perspective that's ending now. We only had 3 minor projects approved, and we cannot participate in the competitions. It is only one single project regarding the rehabilitation of the city. So, regardless of the fact whether they are launched or not, which will not be the beneficiary of that? This is the politics on a different level. The capital city of Warsaw has the marshal that is in opposition to the government, which isn't lucky enough. So I'm more worried, not with whether I will have the own contribution. I know we won't, but we will look for that money. We will limit any possible spending because we do not want to give up on the projects. We stirred up the stagnated situation. Our inhabitants have the need, and we are hungry for next projects, next improvements. We want to expand. We want to revive the city. But there's the risk that we won't be able to afford it from our own means, whereas we don't have access to EU funding. If a miracle happens and that opportunity occurs to have our own contribution, will be a serious problem. Warsaw has over 21 billion. We have 6 billion, and we lost the net amount within a year and a half, even with the compensation. We lost 1.3 billion. This is huge loss for the municipal budget. Our strategic thinking now becomes rather an ad hoc planning of how to deliver the services at a certain level to our citizens, because we are becoming worried that we might be forced to decrease the level or extent of those services. And this means a drastic drop in those 2 parameters. So we are now considering not what other plays may be displayed in theaters or the facilities that we're creating. We have a lot of basic healthcare ambulatories. They have become the healthy senior centers. Our assumption was to have every such clinic with a center of active senior people, and they work wonders. They give the senior people not only the health services, but educate them and spend time in a wonderful way, and to develop their social contacts. This is this silver economy. They have time now to develop their own hobbies and take care of their mental and physical condition. We want to build schools. We need them. We have 6,000 Ukrainian children that came to us. So without a stable system of local authorities having their own income. It's not possible. We know this. In order for us to plan well any project in terms of the vision of the city, we need at least 5 to 7 years, starting with the way we obtain the funding, we create projects, we implement them, then of course in the competitive market, and then giving it to our people in the city.
Rzeszów,
Thank you. Rzeszów, Mr. Mayor, is indeed a problem of refugees. Actually, we face that in all our towns and cities, but Rzeszów is a unique example of that. What sort of support do those people need, and how do they impact the operation of the town? It's about social services, healthcare, education. I mean, it's a healthy city in terms of the migratory processes. Can you share it with us? Yes, indeed. These crises are affecting us, including the crisis. Well, it makes me think of Crisis Fiancé. That we used to have that song in the 1980s, and I'm a crisis mayor. We have the Putin's war, inflationary crisis, energy crisis, refugee crisis, and in terms of building the resilience of our towns, it goes a long way. And this refugee crisis that hit us in Rzeszów, I think in an unprecedented and unimaginable scale, because, well, maybe the numbers of children in our schools are not so high in absolute terms, but at the peak of the refugee crisis, given our population of 200,000, we had 100,000 refugees. If you tell to anyone who has experience, they can't imagine it. And you have to admit that we talk to people who are very experienced when dealing with migrations, such as Germany and or Scandinavia, as well as the US. But the scale of the phenomenon is unimaginable to them. And on top of that, we did it without any refugee camps. We just received them in our homes. So those 100,000 refugees in Rzeszów found their shelter somehow. Now the number of refugees has diminished. We are subject to fluctuations. Sometimes they go someplace to Europe, sometimes they come back, but we should get accustomed to the fact that we will be a town with a significant minority, also hosting NATO troops. This changes the whole story drastically. But like I said, we are a region that is subjected to a test, and it's working. And it stems from the 30 years experience of our local government in our state. And we have jobs in our region. We could offer it, and it's going on. But we have to remember that many of those refugees are ladies with children. But we need to support housing construction, cheap housing construction, the support of the school infrastructure. And Rzeszów won out owing to the preschool or nursery school index. We need to work on it rather than closing down. So instead of taking away what we've achieved, we want to take another step forward. We need to have funding for that, and as we heard, we don't have it. It's not available. So not only should our needs be maintained, we also have new guests new visitors. Most of them are here to stay, and it's going to be a huge challenge. I can give you an example of a Polish company from Gdansk that opened a logistic center. They employed 600 staff. 500 of them are from Ukraine. They will stay here. But we have to also offer public services and integration processes that just don't happen overnight. They cost money, and if we want to perform the integration at a greater level than in many European states, it's going to be a huge challenge. Another challenge. If I may, Mr. Mayor, in this round, we're being hosted by a university. We also investigate or research the public sector. Many researchers claim that public services should be planned at the local level because local governments will cope with the provision of social services better than at a higher level. So can you touch upon the topic of decentralization of healthcare? That's a difficult topic, isn't it? The participation of local governments in, what I mean is also decentralization of public finance. I think we have a particular pathology in healthcare when it comes to funding. As we compare the Swedish model, it's closer to Sopot than from here. But there are some regional bodies that are responsible for healthcare funding. There are special counselors elected to that end. In our case, municipalities and counties have no impact on the redistribution of funds. They can only be responsible for moving hospital beds from one room to another. I'm sorry, I'm just putting it ad absurdum, but one of the things is that those councils should be reporting to the provincial government, and that they would have an impact on the redistribution of funds, just like in the case of the Fund of Environmental Protection, that until recently reported to the Central Fund. However, there were also regional environmental protection and municipal funds. Then they were rationally spent. Also, in healthcare, we learn about some funds being out of control by the state. By the way, now that we are in the School of Economics, we know that certainty is one of the most important things when it comes to investing. Certainty is one of the most important factors to combating inflation, and we are still facing uncertainty. And they keep changing something in terms of healthcare. Either they make a network of hospitals, or in terms of first aid, ambulances. Of course, we are patching it somehow, owing to medical programs, despite our modest budgets, like heart testing programs, the in vitro program that we could probably discuss at length. Used to be funded by the state, and it's no longer the case until the programs for elderly people, but it's all there. It's a very important prosthesis. Without it, we would have a much less healthy society, but it should be decentralized. Many times people have said that every zloty spent on a local basis is better spent than if it's spent centrally. There's no reason for someone to decide whether one street A or street B should be refurbished in Sopot. Thank you very much. We promised if we have questions from the room, very briefly, and may I ask you for very brief answers. I thank the organizers that these two sessions follow each other. There was this road from Madrid to health, and here I have one question. Even if we cannot resolve it today, it's a very valid question for future. It's a fact that environmental pollution of many sorts increase the risk of the spectrum of autism in children. Hence, by having good in towns in terms of the environment, what does the situation look like when it comes to autism and its incidence? I think in Sopot it can look better than. Sorry, the user is no longer using the speaker is no longer using the mic. We cannot hear it. If I may, very briefly, it's not only about autism. It's also about cardiovascular diseases, neurological diseases, all diseases. You could just enumerate them one by one that the environment is responsible for. I won't tell you where I'm not gonna go skiing because I'm gonna be feeling that the host fires the furnace with whatever. I'm not here to criticize other local governments, but you can feel it, you can smell it, just like all sorts of waste materials that create the same situation. One more question. National Institute of Public Health. I have a question to Mayor Fiołek and Mayor Karanowski. Have you thought or talked to each other? And if not, may I prompt to you a great topic. Why, during the pandemic, the life expectancy of males in Rzeszów was reduced by 3 years, and it was not reduced at all in Sopot? I think it's a very valid topic from the point of view of health care. We have to explain the huge differences that occur in Poland when it comes to losses triggered by the pandemic. The professor drew attention to a very important aspect. I think I would go further. And in the Subcarpathian region, the mortality was the greatest, and it would seem that it's the healthiest region and the highest quality of life. So this is a very important problem. To me, as a sociologist, it's correlated with the vaccination index, where many people think that we were inserted a 5G antenna, and owing to that antenna, we will be eating worms. Unfortunately, we still have a lot to do when it comes to education. And we're back to the basics. On the one hand, the high quality of life and high life expectancy, absolutely not correlated with the educational process or the quality of the health system. It's rather correlated with some traditional models of living or a smaller degree of industrialization, shall I say. It's pretty much instinctive to me. However, it's a disaster when it comes to this, and we're facing that already. And we treat this very seriously in municipal governments, but not in the rural ones. Okay. Thank you very much. I think another panel is coming up. Thank you very much for coming. And let me finish on an optimistic note. The local governments have been around for over 30 years. There have been different difficult situations, and they have always coped with them. let's hope it will stay onwards. Thank you very much for this very interesting panel. Appreciate that. On behalf of local government activists, I'd like to take this opportunity to thank Professor Hausner for his invitation on mobilization to participate in today's debate. Thank you very much. Such debates don't make any sense without practitioners. So thank you very much for your participation and a very valuable discussion. Okay, so we are past the local governments, but it will still stay on the practical note because it's time to talk about the role of the health sector in the economy, the broadly understood health sector encompassing both health services as well as pharmaceutical sector contributes a lot to the economy from the point of view of creating services and products, but also as an employer. During this panel, various health sector entities will relate to this while discussing the role of the health sector in the economy and also discuss the main challenges facing that sector. This will be moderated by Zygmunt Kostkiewicz, the CEO of Polski Gaz TUW, and the next panelist Krystyna Nitecka, PR Senior Manager of Polfatar Homin. Please join us on the stage. Professor Wojciech Cyrul, Director of the University Pediatric Hospital in Krakow, who has taken the floor already. Anna Rulkiewicz, CEO of Loxmed Group. Jakub Swadźba, CEO of Diagnostyka SA, expert of the employers of Poland, and Małgorzata Zaława-Dąbrowska, Director of the Outpatient Healthcare Center, Warsaw, Żoliborz. Over to the moderator and the panelists. Good afternoon, ladies and gentlemen. We are to discuss the role of the health sector in the economy, the broadly understood health sector, both as the classic healthcare sector, as well as all those entities that make a living on health, mostly the pharmaceutical industry, as well as all sorts of health-related services that are not directly healthcare services that are part of that sector. We realize that the sector represents a significant proportion of social life, and I'd like us to discuss its economic role per se in terms of the GDP generation and employment, as well as the indirect role ensuring the fact that the economy works well. We know that healthcare sectors are roughly 800,000 people employed in both the private and public sector. It could be further split, but I don't think it makes sense because a large proportion of staff work in both sectors, which means that those statistics don't have to reflect the reality in the right way. The pharmaceutical sector is 1.3% of the GDP. It's quite a lot if you take a look at it from the point of view of the entire economy and without facing it on a daily basis, without witnessing its great economic activity. In the first block of our conversation, I'd like each of you to present your company's perspective to describe your views on the economic role of the industry you represent. I won't be asking each person to speak. I'll just give the floor over to the next person. Good afternoon, ladies and gentlemen. Krystyna Nitewska, Polfa Tarchomin. For many years, because I've been working in various pharmaceutical companies for many years. I worked for 23 years in Polpharma, and today I'm in Polfa Tarchomin. Frankly speaking, the pharmaceutical industry is going through dramatic modifications, huge changes. We know that we are represented by two potent organizations. One of them is the Union of the Polish Pharmaceutical Industry Employers, the organization which is also participated in by Polfa Tarchomin. They have very good representatives in various committees and participate in all sorts of meetings at the governmental level. And here, indeed, we have very good opportunities of meeting and learning about the new procedures that can be somehow presented by the Ministry of Health.
As we know, the budget of the Ministry of Health may seem large, 6.9% of GDP, around. That constitutes 159 billion Polish zloty. Nevertheless, the way it is administered and managed is a different matter. In the pharmaceutical industry, we're concerned with drug security. Drug security is a priority for us. Minister Miłkowski, in Healthcare Challenges Congress in Katowice, expressed his confidence that we have 100% drug security. But a very serious problem constitutes, well, it stems from the fact that we were very much dependent on the Chinese market. We will address the challenges further on. Could you please tell us about the role of the pharmaceutical industry in the economy? We are now at the stage of providing a diagnosis. We're describing the roles of particular industries in the economy. Polish pharmaceutical companies have a large share in the overall situation of the pharmaceutical market and drug production. Polpharma, Polfa Tarchomin, Adamet, and a few others are the largest Polish companies. They are associated in the Association of the Pharmaceutical Industry Employers. We have large development opportunities. Polfa Tarchomin is about to open the factory that produces oncological drugs. The companies such as Polpharma have a large share in the drug production. Therefore, I think that Polish pharmaceutical companies have huge development potential, assuming that the Polish government and the Ministry of Health gives us the opportunity to realize that growth in terms of production in our factories. Welcome. I want to thank the organizers for inviting me. I came here, quite frankly, with this enthusiasm to this forum where I hoped that finally a director of a pediatric university hospital would be heard. Well, some of you might have heard me before. What is specific in the hospitals, such as the one that I represent, is that it's like a cherry top on the cake. Pediatric university clinics, hospitals, are but a few in Poland. They are grand, they're huge in Poland. And two of them that are at the opposite sides of the same street have a joint budget of 2 billion Polish zloty. And the budget of the hospital for adults is twice the size of our pediatric hospital. These are not only big hospitals, but these are big employers. Have 2,500 employees. The hospital on the other side of the street employs 7,000 people. We carry out scientific research, and we carry out clinical studies with huge budgets. They are financed by both private and public sector. These are also big social centers, in this meaning that the hospitals of the third level, reference level, the one that I have the honor to manage, they focus all the social problems that exist in a given macro region. We are a hospital of the macro regional nature. So let me clarify some things. Well, we heard something that is not quite true from the moderator. We do not make money on health. We make money on the disease or illness. Now, while we're mapping some of the problems, if you have a look at the title of this Congress, the way we define health as an issue, we ended up here with healthy cities. I know that I cannot tell you anything about health. What I can tell you about is the disease and not health. Where people are healthy, we have no hospitals. Health is everywhere but hospitals. It's sick people who come to hospitals, and this is the basic problem. People who speak about the healthcare don't understand disease. Health is a capital. And from the point of view of economy, you may calculate that. Even if all the previous speakers did that, I need to tell you the disease is not a capital, it's a cost. It's not only a social cost. I always try to say that whenever I can, it is related to suffering of an individual. Health is public and disease is individual. These are serious problems. We oftentimes forget that there are 3 levels. We should have 3 levels when we look at the disease and we manage the disease. Namely, the most important level is the relation between the patient and the doctor. This is an area of very many problems. Whether the patient can be included in the diagnostic and therapeutic problem or not depends on how costly that process is and how efficient it is. So to prepare doctors to have interactions and to work with patients is the first important matter. And the preparation of the patients, the potential patients, for them to be able to use the system. We forget about that. That's why the emergency healthcare services are overburdened. Now, the second level is people like me, the management, we who manage the healthcare, because we are a sort of entities that seem to channel those anxieties, suffering, frustrations of the patients or their parents. And on the other hand, we are the face of the system, because on the top of us, there's just a huge organization of the state or local authority with anonymous offices where huge money are allocated. But I don't know if any minister ever had parents of a dying children, asking them for money for next therapy. And I happened to have that visit in my office. It's a life-changing experience. I do not wish you to have such an experience where you can, only thing you can say is that I cannot do anything. I'm also a parent. That's difficult. Even doctors are often not prepared to have that types of conversations. And doctors of hospitals are definitely not prepared for such an experience. So the problem that we have is not only the matter of asking questions, have to create a better world, have clean air. It's a little bit naive. Please don't take any offense, but maybe my practice or my everyday work make me less optimistic than my colleagues who came from Brussels. Well, I used to work in Brussels. On the low level of slogans, it's beautiful. When you enter the hospital, it's overburdened. People have burnout. They're underpaid. Majority of the healthcare staff can earn, good money, but that's the matter of the context. They receive no help. So the problem of burnout is visible just now. The understaffing, terrible regulations that make people who provide healthcare services of the liability for the consequences, including penal liability. Many of those problems of the drugs that are there but are not refunded, they're not reimbursed, they're not available, all of that contributes to the frustration of healthcare professionals. Well, a lot of children or patients leave Poland to have their treatment where they do not know that in Poland they may have that same treatment in Poland and for less money. I will give you an example. In Krakow, proton therapy, which is the most expensive way of treating cancer, is available. But until this year, children used to be transported to Germany or Czech Republic, where that was reimbursed. And in Poland, it wasn't, although we had the specialists and infrastructure. We need to be wise in using both the human and infrastructure assets that we have, and that's the key to success. Thank you. Well, thank you for emphasizing the role of this sector as an employer. What I'd like to add is, in Przemysl, quite a large city, it's the hospital, the Wojewódzki kind of regional hospital that is the biggest employer. We appreciate the role of hospitals because it's considerable. Let me go back to the question. Could you please ask it again? Because we addressed various topics, but I'd like to refer to economic part. I'd like to speak about the role of healthcare in the economy. In your case, it's the private healthcare's role in the economy, both macro level and micro, if possible. Let me take that from another perspective, not by speaking about the disease, but when we want to address the influence on the economy, we need to talk about the health. To be able to have the working people in the best possible health as long as possible. This aspect is really important. I think we should address it, although we neglected it today. This is the health prevention. The prevention is what makes people healthier longer. It's then less costly for the employers because people do not take sick leaves. We had 24 million sick leaves in 2021. It cost over 24 billion, and 60% of that was covered by the public insurer, and the rest of it was covered by the employers. So when we talk about the impact on the economy, it's this: the healthier the employer, the better is the economic result, because people come to work and they are not absent from work. We spend very little on prevention in our country. It's around 3%. Now it's even less. just a bit over 2%. All of our expenditures of the National Health Fund is for the restorative medicine. And then it has really limited impact on the economy. It's either life-saving or to restore the health of people who might go back to health. When we talk about the economy, we need to address how to limit the sick leaves rate and the costs for the employers so that the people who come to work are as effective as possible. I'm addressing this aspect because it is really important economy-wise. Maybe some numbers about the private sector. I agree. It's often very difficult to speak of the number of employed people in this business because many healthcare professionals work both in private and public spheres. But it's not only the doctors and nurses, that's the majority of them. But what's important is that in the whole industry, in general, in the healthcare, we have 700,000 employees. That includes people who work to the benefit of the healthcare sector. It's a very large population of working people who perform the work in this area. So they either work to maintain the patient's health as long as possible, or they restore patient's health. The way I understand it is we need to fight for the direct and indirect costs to decrease the absence of employees through very good preventive programs. And one comment. I recently read that, for instance, if an individual takes care of their own health, and this is not done in a systemic way, then the return on investment for that individual is much lower than if that solution is introduced by an employer, for instance. The health checkups or some other programs, we are able to gain more effectiveness once we do that in a systemic way. Thank you very much. Good afternoon, ladies and gentlemen. The role of the healthcare system is really important in the economy. Thank you for the invitation to this event. I'm happy to participate in the first Congress that draws our attention to the link between the health and economy and shows the results of that. That encompasses very many areas. Healthcare protection includes medical services, pharmacy, science, insurance, health insurance. I think that the pandemic uncovered and showed clearly to everybody how important it is to secure the healthcare staff and to have all the logistics correct, plus to maintain the everyday operations. I've been a director for a dozen years already. Work in the public outpatient healthcare clinic owned by the capital city of Warsaw. We have 12 outpatient clinics.
We have a whole panel of GP practices, specialists, dentistry, psychogeriatrics, our own CT lab. And well, let me just tell you that our set of clinics, despite the difficult financial situation, it brings a profit. It earns a profit of from 2 to 8 million zlotys. For our own funds, we bought several years ago our own CT and MRI. So yes, you can do it. But coming back to this, with these 500 or 800,000 people are not only therapists and nurses employed here. It's an entire system of activities and an entire network of other companies, for instance, pharmaceutical companies. This is employment to the providers of pharmaceutical and medical equipment, and so on and so forth. When it comes to the links between our sector and the entire economy, well, the good medical service triggers the fact that we have healthy employees. Don't know if you remember that of yore there used to be local clinics because they took care of health. Now we only have labor medicine. Maybe it should have a greater role. Also, another important thing is the impact of expenditure on healthcare to the growth of GDP, let alone the billions invested by the National Health Fund. It's still well, but invested into the sector. However, we still lag behind the EU average. We have 8.8. We have 6-7% of the GDP, depending on how you calculate it. When it comes to the problem touched upon by my CEO, let me tell you that in our clinics, we provide many prevention programs. There are many prevention programs are in place, both in our clinics as well as in schools that we supervise. These are prevention programs funded by the National Health Fund and the municipality of Warsaw. Maybe it's not the right time to discuss it, but maybe we'll have an opportunity to discuss it later. Thank you very much. Hello, good afternoon, and the topics are quite general. So let me just allude to the prevention as Diagnostica company, an entity that only deals with diagnosing rather than treatment. However, we are very much interested in prevention. Let me tell you that there's been a very interesting solution, Prevention 40+, that was developed at the ministry level. It was supposed to be created as an idea with a thought to hospitals and GPs, without thinking that 50% of labs in Poland are private labs. And actually, in the open outpatient system, we're talking about 75%. So 2 weeks before launching the program, they realized that there was a company such as Diagnostica. Maybe the program should also be launched for them. Well, they are private, but maybe they might help. And at the last moment, we told our IT colleagues to join in and connect with us with P1. Then we had to do some stupid things, such as buying 1,000 scales with a special attestation, because you couldn't access that program without that. Well, before our competitors Synevo, because they couldn't get hold of those scales, and at the end of the road, we performed 75% of the national prevention program, 40+ prevention. So, well, that's how you go for it. PPP without the intention to do so. Just like during the COVID, when we combated with the ministry, where the private entity should be able to mark COVID. Well, there are some countries where you could not do it. For instance, in Belarus, but we were able to register those 3 out of 50, And indeed, we had a huge potential at that time. So to give you some better flavor of it, to beef it up a little bit, I'm driving the discussion towards a certain antagonism between the private and the public sector, although I believe we shouldn't do it. And whereas I'm definitely in favor of the private economy and the departure of communism, which we are failing to do recently, and right now, actually, since we entered the democratic life, unfortunately, our medical service is very old with very large shadow economy spheres and ill things that are missing. I think that we believe that such immeasurable items should stay in the public sphere. And I'm here actually in three hats here. On the one hand, I'm the owner. On the other hand, I'm the manager. And on the third hand, I'm a doctor. So I'm trying to understand it through the perspective of those different hats. I believe that those special cases, those cherries on the cake, should be state-owned. We have very rare cases, and like for instance, we mostly treated most important people, mostly from the right. We did not look at the cost. Everything was available. If something was not available, checking code someone and the organized medicines. So that's the beauty of those things that should stay, because the private entrepreneur doesn't find it logical. That's what it should be. So university centers that you're presenting here, and when it comes to comparable things, the 9 county hospitals that Warsaw has, I think it's a shame that it should belong to the municipality. I mean, this outpatient clinic, which is working well, and it shows that it can work well. But a colleague of mine, Andrzej Ryś, who's an EU expert for many years, and he actually worked in my company as the director of development for 2 years. He was the first municipal physician of the city of Krakow, and he actually privatized all the clinics. I think it went in a better direction than it is in Warsaw or Łódź, which function quite well if they have good managers. So it's not entire criticism. I just wanted to enliven the discussion. Okay, I believe that the Polish healthcare system is a very complex patchwork of the public and the private sector. And I believe that there is no single piece of health services that are only state-owned or only private, because even in dentistry, we still have public clinics, as Madam Director mentioned. I was planning on 2 more rounds of questions, but given the time constraints, I think we'll combine them. I'd like to ask you about the prospects and threats to your segments of healthcare and pharmaceutical industry. From the point of view of the pharma industry, it's a problem of the medicine policy and medicine safety. And for all the other sectors, it seems that the single most important problem is the population aging, which will have an impact both on the supply and demand of medical services. Let's start with you, Madam Director. Ladies and gentlemen, I mentioned medicine safety too early. It's a huge problem, and as medicine manufacturers in Poland, we worry a lot about it, because it is clear that we are very much dependent when it comes to active substances that are necessary for the manufacture of medicines. We're very much dependent on Asia, specifically on the country of the center, where but this is common knowledge. I've always been interested in something more practical. how much more difficult, how much more expensive it would be to inshore or reshore that production. Well, we know that the Asian market is definitely cheaper than the European or American one. However, right now, owing to the threat that exists, it's clear that the Chinese are allies of Russia of sorts, and we don't know what it's going to be like of API to Europe. You cannot view it on a purely cost basis, but from the perspective of the patient's benefit and to be able to manufacture the appropriate amount of medicines, you have to be on the safe side. Minister Miłkowski claimed definitely that we are enjoying a medicine safety on a 100% basis. We, as manufacturers of medicines, believe that this is the case. However, this gives rise to huge concerns to medicine manufacturers that active substances might not reach us in the appropriate amounts that could contribute to the production of all the medicines necessary in Poland that are indispensable for our patients. Thank you. Unfortunately, we cannot hear the speaker. The mic is wrong. The mic is off. Sorry. I'll be brief. From the point of view of a pediatrician, the problem is not about the aging society. It's about the number of children being born, and it's also the procreation state policy and what sort of diseases we have to deal with in terms of pregnancies that had been terminated previously. Another problem is a lack of specialists in pediatrics. Pediatrics is, by the way, much less attractive to physicians, and we have a problem in attractive young specialists or even residents to specialist universities. Another problem for university hospitals is the relationship between the university and the hospital. Many people fail to understand it, but we as university hospital directors are also responsible for the teaching staff and vice versa. So directors are responsible for the teaching staff and vice versa, because the right staff at the university determines the funding of the university, and the appropriate staff at the hospital also is reflected by the appropriate funding for the hospital. Unfortunately, it's very difficult to reconcile it. Before, they used to pay better at the university. Right now, they pay better at the hospital. So people shift their positions, and we have to balance it somehow and strike a balance, find some agreement. You have to remember that doctors, as physicians and as researchers, actually work in hospitals, so they incur the costs in the hospitals, and the money from the Ministry of Education is sent to the university. That triggers many problems of operating costs, let alone the costs of services or the medicines that we buy. It's true for all the sectors. However, something that was visible on one of the slides today, the increase in the diagnostic costs and treatment costs stemming from the progress in medicine, the so-called medical inflation, other than general inflation. It's huge. It also triggers the growth of patient expectations. I'm afraid we cannot meet all those expectations to enable everyone to gain access to the most expensive medical services. This is both an ethical and social and legal as well as economic problem, and you have to realize that. And at the end of the day, we have the macro issue, the way of funding of medical provisions. Let me just tell you one thing. It's created based on the data gathered from all sorts of hospitals, the recommendations, proposals of medical service prices. Well, the problem is that at the general level, it might work well, but if you have the third reference level, it turns out that we have the same pricing of the procedures as for general hospitals that have definitely less complex cases and less complex procedures. It has to be provided in a different way. Our hospital is also profitable, but we will never be able, such hospitals will never be able to develop fully and attract the best medical professionals. And not only medical professionals in such entities. So something has to change rapidly, otherwise we'll be facing a major problem. It's hard to speak after you, Mr. Professor, because you just, well, but let me just try to expand it. Let me start with the aging society. We're not aging in health, we're aging in disease. Our population is sick, which involves greater costs because the costs of treatment are greater. This is very important, let alone the fact who will be working for those people. That's also connected with the fertility rate. And so basically this is also about the pricing of procedures. It's morbid. What you said, it should go without saying, because there are such specialized entities that should have very good pricing ensured. I'm just surprised by what you said, that your hospital is profitable. Congratulations, because this is very badly priced, especially in geriatrics. But it's a matter of pricing. On a macro scale, I keep repeating, it's very difficult ensure good healthcare in a 40 million population with a single payer.
What we have is one paying institution, and they will not have more money now. The expenditures of the National Health Fund is increasing the budget, but it's still below the inflation rate. The overlapping problem is that there is not enough medical health care professionals, doctors, nurses. They're missing. We were not able to extend some competences in the medical professions. The nurses received the legal grounds for that, but the habits are habits. They're often afraid to use those new competences. So we seem to be working in an old way. We do not use the rights that the legislator provided to us. With aging staff, there is a gap. We do not have the middle-aged like nurses. So we have the older ones and the young ones. There is a gap where we do not have enough middle-aged nurses. When we compare the number of nurses and nurses per capita compared to EU, that's really low rate. The financing of the system itself, that is based on one payment institution, is where the patient have no choice about the payment institution, and the financing should be diversified according to several factors. So some people that can afford more, or some services can be covered by the private practice, private health insurance. That is how it functions all over the world. I think that financing is difficult, is not correct in Poland. The national payer really does not need to cover everything. There is the pool of the guaranteed healthcare services, and politicians are afraid to touch upon that because they know it will be difficult in terms of the elections. Some of the procedures need to be reconsidered. We need good pricing of the healthcare services and procedures, and apart from that, something was done in the country. We have minimum salary, and people have claims. So healthcare professionals and other staff, should they earn this or that, or the debate is ongoing, and there's inflation on the top of that. But there are new technologies coming in, and we cannot afford them because we cannot even afford the basic services that are guaranteed. And afterwards, many public hospitals have to maintain the non-profitable procedures, and the private hospitals don't want that because they will not add their own money to that. We have macroeconomic problems that we should solve as a country, and unfortunately, the health is not beyond the political differences. So it's difficult to continue a long-term strategy. Well, health is not present in the public debate. There are no ideas there. In other domains of social life, there's an explosion of ideas. Yet in the health policy, apart from very general slogans that it needs to be better, we cannot see anything. People don't have courage to do that, to reform the healthcare. We need to say which hospitals are needed and what role should there be. Well, nobody wants to do that, and that has been present for many years with all the political parties. But health is a political matter, and it's not good for the long-term thinking. If government introduces some first steps of reforms, then, you know, the majority of spending goes to hospitals and not the simple prevention to maintain people in good condition, but first contact doctors that should take the burden out of the hospitals, because people with trivial problems go to the specialist hospitals, as we need to reverse that pyramid. It hasn't been reversed so far. It's important to be consistent. Well, I don't want to speak this whole panel time, but there are so many problems. When we think in a 5 years perspective, let me address what has been said already. The health is in the slogans of the politics, and it shouldn't. It should be the matter of the discussion among experts and not the politicians. I'm a pediatrician and allergologist. My personal motto is my priority is the well-being of my outpatient clinic. And I managed to really take it into a good financial standing. In Warsaw, we don't really have that old type outpatient clinics. These are like companies, smaller or bigger ones. Not all of them are profitable, but it's not the priority for the healthcare, but they need to be well organized. My nearest perspective is, pardon my language, it's the fight for the staff, and that's very unfortunate. We are all struggling with not enough employees, and this competition is not right. That should be based on the expertise. Well, we should fight for those people to come here and implement those new, innovative, expensive procedures, and yet we compete to have basic healthcare personnel, nurse, doctor. So pay attention to this. There were many aspects that were neglected. In 2015, we had 15 medical universities. Now we have 24 ones, and we are about to have 27 starting from October. Is it good? Are we educating doctors, or do we produce doctors? There are medical faculties in universities that don't have traditions or culture, which is important because you need to have those in medicine. I am a doctor that learned from master, and it is regrettable that young generation has a different approach. So I have classes with 6-year family medicine students in Warsaw. I'm accredited to have that specialty, but I am concerned with the level of education of young doctors. Well, this is one perspective, the education of young doctors. And the second one is the following. We have been talking for 15 years at least that we want to reallocate expenditures and not the funding from the hospitals to the first contact level. That will generate savings. It will give us good organizational results. But it's not happening. Now the opportunity presents itself. My outpatient clinic, as one among 2 in Warsaw and 46 in Poland, took part in the pilot program where we gain terrific experience, and we want to translate that into what patient can experience in family medicine. We have the family doctor, we have specialists, we have everything. So we enrolled in a program of medical coordination. We want to create individual plan for medical care for patients. We are trying to reorganize the way it works, and I perceive that as a great opportunity. It is difficult. It requires a lot of work. It requires the change of mentality in patients, and the changes are difficult. All of our employees at every level really take time to get convinced to change something. So for our employees, it's an additional payment, and for the patients, it is very beneficial as a perspective. And telemedicine is another aspect. The pandemic showed that there are new forms of giving medical advice, but there are threats of criminal nature. So we want to use the advanced technology in working in the medical domain. E-prescription, e-referral. These are solutions that will give us a lot of opportunities for growth. Thank you. Thank you very much. I'm really happy that we are discussing the digitalization, but one word is missing. It will solve many of your problems with doctors, maybe not so much nurses. ChatGPT-4, AI, ladies and gentlemen. It will be a breakthrough in medicine. Some people say that in 5 years, this world will not be the same. Medicine is so resistant to change, so 5 years is too optimistic of an estimation. But we will see that. Telemedicine, and I'm very much in favor of that. Although sometimes, as Minister Cieszyński, a yet new minister, is a great solution, but e-prescription is a situation when you don't even need a chart, you just need 50 Polish zloty, but it constitutes a threat. 5 years ago, we had a large grant in histopathology, and it was a successful project. We used AI to detect prostate cancer, and it hit 55% of accuracy. Our doctors revolted against that. They said, oh, we're not going to do that thing. We're not replacing doctors. What we wanted to do is to do some screening where the AI might suggest some of the spots. We are notorious as that bad employer that forces doctors to carry out crazy amount of histopathological tests per minute. So we wanted to just facilitate our work and make it more efficient. Our doctors did not want to do that, but in radiology, there was software with AI, and it really suggests the diagnosis. FDA confirmed some of those, approved. At some point, we had to stop AI, get certified, carry on with research, elaborate some new types of devices. And now startup companies are working on apps that the doctors may download on their computers to use for radiology analysis. I know that in years to come, we'll have the applications by bigger companies like GE or Samsung. Radiology is not the only domain, but the only experts that can be on the safe side are the psychiatrists. And they said, no, the psychiatry is the place for AI. They may continue the conversation with a patient for 4 hours. It doesn't need to get paid 350 Polish zloty per hour. So I think 27 medical universities that will produce the doctors that I hope will be good doctors. They can really get unemployed. But we won't need so many of them, or we may be looking at that profession in an entirely new way in 5 years, because we need the contact with the patient, so the GDP chat will not be the only form of a conversation. Well, we failed in securing time for questions and answers. I hope that now you have a better picture of the role of healthcare system in Polish social life is much more optimistic than in the economy, and I hope it was interesting for you. I'm very grateful to all the panelists. That was a really interesting panel discussion. It has been the last part of our Congress, the first Congress, Economy and Health. Thank you very much for this heated debate. Ladies and gentlemen, it is the moment as well to sum up this day and everything that happened so far. Thank you very much. Ladies and gentlemen, let me invite Professor Jerzy Hausner, the head of the Program Council of this Congress, and to provide the closing of this Congress, also together with Professor Piotr Wachowiak, the Dean of the Warsaw School of Economics. I thank you for your attention on my behalf.
Proszę Państwa, to nasze pierwsze wydarzenie.
It has been the first event of this type, and certainly we're determined to continue. It will take a more developed form. What I'm about to say is a form of just thinking out loud, on how to approach a project. I was listening attentively to all the debates, and very often we heard the word crisis. There was the crisis related to pandemic, humanitarian crisis, climate crisis, energy crisis, and when we combine all of that, it affects the health. The first panel after the opening with the representatives of the Committee of Health, Committee of the Polish Academy of Science, and we heard about the Polish project Health 2.0. It made us realize that there is a health crisis. It is not only in terms of excessive death rates due to pandemic. Starting from 2015, and this is visible in reliable data, the trend stopped the trend of longer life expectancy. And from the pandemic, this trend reversed, so the life expectancy went down. Many factors contributed to that, climate change included. So we cannot say there is one factor that caused it. There's a natural tendency of linking the health problems with economic dynamics. We speak about how much percent of GDP is allocated to health prevention, and so on. Let me say that clearly. The link between the economic dynamics, GDP per capita, and the health state of the society is not so clear. When we hear that, when we give this synthetic measure of the life expectancy, and we can hear first stagnation and then regression, yet we have been experiencing economic growth from 2014. In the pandemic time, 2020, it slowed down, but it went back up again in 2021. And last year, in the peak period, this dynamics quarter by quarter was at the level of 8% of GDP. It was a very good time for the Polish economy, taking into account this one indicator. At the same time, we can hear there is a health crisis. It's obvious that GDP dynamics cannot guarantee anything, and it has inflation as a driving factor amongst others. It is true that when we have a look at it from the point of the problems that were described here rather than the results, many of those problems we heard throughout the whole panels. Healthcare system, not only in Poland but in many other countries, is not satisfactory. I guess there is not a single country where it is satisfactory. We're facing a problem of a huge increase in demand of healthcare or health services. At the same time, the costs are growing hugely. Inflation in the medical services is much higher than in the general inflation as such. What is important is that the system that was described here in detail, it works worse than it used to. We heard people who were giving their presentations and speeches here, and more referring to any mythical period of prosperity of healthcare in Poland. It never worked well, but it works worse now. Just a small digression about the health debt. I will not, debate with the health experts in terms of health deficit or health debt, but health debt is definitely visible when we talk about the debts of the hospitals. I congratulate you, Director, but you're an exception rather than the rule. In Warsaw, the great majority of hospitals are in debt. And it's not only hospitals that are in debt. There's a problem of shortage of drugs. Antibiotics are not available in Poland. Regular diagnostic tests and treatments are performed not frequently enough. So let me say that clearly. It is justified to speak about the health debt when we are addressing the phenomena that we require more financing. But when we finance things with the so-called empty money, it does not raise the quality of those services. We say, give us more, and we get more, not on regular terms.
Bez reguł.
Without a system, without any rules, does not mean that whatever we receive helps us out. It can help patch the situation. Funding with empty money is not sustainable, and it will always pose a threat to collapsing the system. But most importantly, funding with uncovered empty money, it disturbs the system, disrupts the system. It's like one of the speakers says, you had to give a phone call and take care of it. There are two ways of looking at the health system. I'm not discussing the policy, I'm talking about the system. One of them is classic. We can never give it up. That's the perspective of health risks. The perspective that makes sense if we have recognized those risks. That's evidence-based medicine. If you don't have such research, if you don't have that base, well, that has been quite vocally discussed. Another issue is the prevention. That's what well-constructed health programs should work on. However, not prepared on an ad hoc basis because of some event, but just because we analyze the health condition of the society and adjust it to the program. The third component that has to work is monitoring. We see how this is being pursued and whether what we are counteracting is really happening. But finally, and most importantly, is the systemic reflection, because the set of factors is changing. It cannot be constant. If it's changing, that means that the health system has to change. It has to be subject to some procedure of making smart and systemic alterations to it. That was discussed by Professor Więckowska by indicating certain issues that have been put forward as part of the existing system. What could be done to improve funding? What does it look like generally? Let's take a bird's eye view to the history of the insurance-based health reform that we've been working on since 1999. Let me remind you of the Krankenkassen and the reform made by the then government. I was unfortunately a member of. But what is the National Health Fund today? That's actually the return to the manual management, absolutely centralized, and where the financial leverages don't work in line with the knowledge that they should, which is also testified to by the whole pricing of medical procedures and everything involved. The fact that we have no contributions of those insured, and of course we can ask the question whether the system was prepared for the pandemic. Of course it was not, but could it have been proposed? Could any system have been proposed? Well, I don't think that's the right question. The question should be, Was the state prepared for that shock? And could it have responded appropriately? If we're talking about that response, then what dawns on us immediately is a different perspective of the healthcare system, namely its resilience to shocks, not coping with problems that we know, we recognize, we know how they work, and they're predictable, because we could have predicted a demographic change decades ago. And the fact that there would be a problem with children's hospitals, we could have foreseen it way before. We're talking about whatever is not foreseeable. That is a shock that we cannot foresee beforehand. And that's what we are talking about, the resilience to the appearance of such shocks, which will come in abundance. And I don't believe that any system, healthcare system, can have enough funds for to cope with such shocks. It's not feasible. That means that it would not be sustainable. So where should such reserves be? They should be intersystemic. We're talking about also the civil and defense related procedures. We have them for such situations. Maybe we should also have such thinking in terms of the health system. But most importantly, we should realize that there are no mechanisms enabling us to respond to everything at once. That's why it's not the ensuring the response, but it's the recovery aptitude. But most importantly, we need a shift. Resilience is about shifting. When experienced by such a shock, I cannot foresee any other shock, but I'm reinforcing the weakest components of the system, so which means availability of quick response, and on the other hand, the ability to think strategically. The healthcare system is always multifaceted. There will be many actors, and the question is to what extent those actors are supposed to be autonomous, and to what extent they should be integrated on a partner-like basis. Both aspects are indispensable, and the reason we included the municipal aspect of this, because we have the Healthy Cities Index, and we want to show you that this look at the cities should make you realize that in thinking about the independence and autonomy versus integration, we have the municipality, the city, that is the most important center. The city is not about restoration medicine. It should not be dealing with it, but no one can dismiss the city from the responsibility of dealing with only the morbidity-based aspect of health, but also the quality of life, the level of living. Thank you very much. These are the thoughts that I'd like us to develop further on. I wish to thank the President, Piotr Wachowiak, for enabling us to hold this Congress on your premises. I bow to you, Mr. President. Mr. Professor, dear ladies and gentlemen, I have deliberately invited the professor to take the floor before me to simplify it for me, because after the professor's intervention, it's very hard to add anything. I agree with every word you said. But the most important thing is that probably everyone, each and every one of us, believes that we have food for thought and for discussion, and that's the first Congress, economy and health, but definitely not the last one, because I believe that those two words, like I said at the beginning of today's Congress, are very important, and we need to be able to combine them appropriately. From this very interesting discussion, we can see the main aspect of healthcare funding, not only when it comes to the amount of funding, but what the professor has emphasized. It's very important that, as well as the participants of the last panel emphasized, that this funding should be as rational as possible so that the funding should reach where necessary. Of course, such challenges that you attracted our attention to are much more numerous. We will be thinking about it along with Mr. Professor, with Professor Hausner, about what the main topic of the Congress should be in a year's time, and I can already invite you to the second Congress, Economy and Health, in a year's time. I'd like to take this opportunity to thank all of you, thank Professor Hausner, Mayor Renata Kaznowska. Those people have been very helpful in the organization of this Congress. And also, when it comes to the Warsaw School of Economics, I'd like to thank Professor Agnieszka Chłynda-Minczak, the Deputy President for scientific aspects, responsible for the organization of the Congress, on the substantive aspects of it, and the person who was responsible for the organizational aspect of it, of the Congress. And I think you also believe she did a great job. Piotr Glenn, thank you very much for the very good, splendid organization. And I think Piotr also deserves a big round of applause. And of course, all the others, all the cooperants. I can see Małgosia, who's been helping Piotr, as well as other people involved. Thank you very much. Thanks to the attendees, the panelists, and Professor Hausner again. And I'm hereby closing the first Congress, Economy and Health, and you're all invited to the next Congress in a year's time, roughly at the same time of the year. And also, many thanks to the moderator as well. Thank you very much, and see you again.